Welcome everyone to the 2022 PSO annual meeting. My name is Adam Novak. I'm the Director of Safety Initiatives at the MHA Keystone Center, and I help to oversee our patient safety organization. So I will be providing some updates today just in what we've seen in our data in the last year, and some activities that we have upcoming and the activities that we completed in the last year as well. But I wanted to give a brief introduction of our PSO team here. Brian did introduce the newest member of the Keystone team, Sarah Scranton, our Vice President and Executive Director of the Keystone Center. So a huge welcome to Sarah. We're so excited to have her on our team. And then myself, Clarence, who's also a newer member of our team, is the manager under our PSO, so you'll be hearing a lot from him and seeing emails come through from him. Many of you know Derek Beach, our coordinator, does a lot with culture surveys and a lot with data abstraction and analysis. And then also Janice Jones, our office coordinator, really keeps things at the PSO moving behind the scenes smoothly. And then our chief medical officer of the MHA, Dr. Gary Roth, who also serves as our credentialed medical professional on the PSO team as well. I'd like to begin these updates before we get into the data pieces and some of the heavier aspects of what we've done over the last year and member accomplishments, things like that. Just to give you some demographic information on our PSO, we have 131 hospital members. Those are individual facilities. Many of those are within systems. 28 critical access hospital members, 12 Indiana members. And then we've actually had 13% growth in terms of membership, number of hospitals who have joined our PSO in the last 3 years, and a number of prospective members have reached out to us as well in recent months. So we're certainly continuing to grow and to try to expand the work that we're doing within Michigan, within Indiana, and along with that comes more member engagement, more data. We're able to do more with that. So all positive news on that front. Now I wanted to get a little bit into some aspects of our data just to show you what it looks like in terms of submission over the last year, but also right now, what we're looking at on this slide is about 3.5 years worth of monthly trended data. This is harm type. And so I'm not going to spend a ton of time on this slide or the next slide, but we will be kind of pulling apart some of the data specifically in a 3-month period that that kind of stood out to me as I was examining this at the aggregate level. But I went ahead and put a vertical red line in here, similar to what I did last year, to designate when the pandemic really officially took off in our region. And the reason I say officially, we know that COVID-19 was here in the US long before the first case was actually confirmed and announced. But within Michigan anyway, our first case was in March 2 years ago. It's incredible that we've come so far, and it's been 2 years. And actually, fun fact, for you, I should have put this in trivia, but the last official in-person MHA wide, so the entire MHA, the last official in-person event we had was the 2020 PSO annual meeting, which took place 1 day after the very first case in Michigan was announced. So it's kind of a milestone every time this event comes around that I have to recognize. But you can see moving kind of to the right side, right after the pandemic started, we started to see some changes in our data and the reported events that we had, specifically with falls, with pressure ulcers. There's a number of hypotheses around that, and I'll be showing some updated control charts here in a little bit. And then we saw decreases in surgery and anesthesia-related adverse events as well because of postponing elective procedures and things along those lines. So we continue to look at the data trended across time. One thing I will point out, just as a caveat here, you'll notice the last maybe 2 or 3 data points, the last couple months leading up to December of 2021 is when this data runs through, because there is a data lag. it gets a little volatile. There's some spikes and sharp dips. A lot of that is due to a lower denominator. So we always see a regular normal drop off in events reported at the end of the year and kind of in the early month or so of the year as well. So just wanted to point that out. Now we're looking at the same data again, 3.5 years trended by month. This is the proportion of our overall data set as split up by where the event took place. So the unit or location, if you want to think of it that way. And nothing really has changed here. This is what we've seen historically throughout the years with our data, the vast majority being in the inpatient general care setting. And then sort of a distant second place will be the ED events happening in the ED. So nothing major to point out here. Again, the caveat, those last couple data points are a little volatile because of differences in the denominator. So I wanted to now go through an illustration or kind of an example of how we look at data and the importance of all of you as members entering data, but also helping us with this analysis, giving us tips, giving us starting points. Every year, dozens of members of our PSO reach out to us and do drop us a hint or ask us about, what are you seeing in this data, or we're struggling at our organization with a certain type of harm, or this has spiked in recent months. Can you look at the 30,000 foot level across the PSO to see if others are struggling with this as well, or what information and lessons learned we can glean from this, and perhaps, should we convene a member forum around this, et cetera. And so this is one way in which we look at the data. So when I was trending, and again, this is across 3.5 years, the same time period that we were looking at for harm type and unit location, the adverse events, except now it's split out by harm severity. And there's nothing inherently odd about what we're seeing proportionally. So the vast majority of the adverse events reported to us are no harm events, which still contain a ton of learning potential. And then and this holds true historically, the second bucket of harm severity that is the highest would be mild harm, and then everything else you can see is crunched way at the bottom, and we would have to zoom way in at a granular level to see the spikes and dips that are occurring with death events, severe harm, as well as moderate harm. But just for our purposes here, we're looking at this big dip that you can see that I've highlighted with a red box, this large decrease in no harm events and mild harm events. And then when I put the numbers here in this call out box, when we looked at the other harm severity levels as well. So when we did an analysis and zoomed in on those, we found that all during that 3-month period of time, December 2020 to February 2021, all harm categories, including no harm, decreased pretty significantly. And I included the number, the N, as well, which I think is important. I wanted to call out, for instance, when we look at the death events, over the course of 3 months, those decreased by 9 in terms of how many were reported, which doesn't sound like a lot, but for our PSO, typically we only see about 25, maybe 30 death events per month. So 9, a difference of 9, is actually pretty significant. You can see that there, that was about a 41% difference. So we use that as kind of the 30,000 foot level view. We see this big dip. My initial thought is there's a difference in the denominator. I went and looked at the data. There was a slight difference. So we did have a lower denominator, which certainly can lower or raise the proportion of what we're looking at and the number of reported events in different categories. But it wasn't such a big difference in a denominator that I would have expected this level, this magnitude of a difference. So we began exploring this a little more. And what we did is we took that 3 months worth of data, and now we examined it by the types of events, the harm categories that were happening. So those ARC common format buckets we look at. And what we found is that within those 3 months, we saw pretty significant increases in device or medical surgical supply related harm, as well as surgery or anesthesia. And then we also saw sort of a corresponding decrease in HAI events. Again, I put those percentages as well as the numbers there for reference. And so, and then we looked at it as well in kind of the next box there. We looked at it by unit location. So I'm just giving you the data that had significant increases or decreases here. But we saw 16% increase in events categorized as laboratory or lab type events, as well as a 14% increase in those in the OR. So what we chose to do, just for the purposes of the analysis today, is take that device or medical surgical supply bucket. So you can see how we're sort of taking a tiered approach. We're starting at super high level, 30,000 foot view with about 32,000 events total that were submitted to us across those 3 months. And now we've narrowed it down within device and medical surgical supply. About 930 of those events were device medical surgical supply. So what we did is looking at that even further, now that we have those 930 events, we ran those through basically what amounts to a word frequency macro, which is kind of a fancy way of saying it's a simple program that takes the anecdotal information, all of the written descriptive information submitted across those 930 device or medical surgical supply event reports, and it ranks, it tells me how many times every word or combination of words appeared across those 930 events. And I put the top 5 here. If you look at the bar chart on the left side of the screen, when we ran the data for those 930 events, these were the top 5 most commonly occurring terms or combination of terms across all of those events. And so the number 1 here is tube or tubing. And so now we've filtered down from about 930 events to below 100 events. And the importance of that is that now our PSO workforce, our staff, are able to actually lay eyes on the event records. So when we have 32,000 event records, we're not going to go through and individually read through every single one of them to determine common themes and patterns and things of that sort. But now that we're below 100, we're able to go in, get our hands dirty, and kind of manually pull that apart and figure out what we're looking at. So I've posted or included kind of our findings and some themes that we lumped everything into within those events that specifically mention tube or tubing within the device medical surgical supply category. And what we found is that it really fell into 2 or 3 different buckets, if you will, different themes. One is that we saw a lot of expired collection tubes. So things like blood collection tubes, a lot of expired equipment that had to be discarded, that had to be thrown away. And then that also led to shortages in that equipment as well, just because nobody was really keeping track or aware that they were expiring. And so when they needed them, they could not use them. So that led to delays in care. You'll also notice that the 5th most common word or term that showed up was delay. So I think there's linkages there. The second thing we found is that a lot of the collection tubes were malfunctioning, specifically with the tops. The tops were warped, they were cracking, they were leaking whatever was inside them, which caused, again, not only delays in care, but potentially redrawing labs, an additional poke for the patient, which could lead to harm, certainly, and it does in itself constitute unnecessary care, unnecessary harm. And then the last thing we found, which I thought was interesting, and this was not my initial, where my mind went initially when I saw the tube and tubing category kind of come up. I was thinking more along the lines of the lab tubes, but the pneumatic tube system. So we found that there were quite a few reported events that had to do, again, within that device category with the pneumatic tube system, specifically backups within the tubes, the system itself breaking down, and again, leading to significant delays and potentially redrawing labs. So the information, the product was not getting back and forth between individuals in a timely manner. So all this to say, you know, it's interesting that we focus a lot on high harm events, right? The ones that are in your face, the falls, the medication events, things that happen very frequently and a lot of times can result in high harm, surgical never events, things like that. So this is an example of how we can draw some lessons learned or better investigate by drilling down to the bare floor level into events that may not lead to or result in high harm, but could down the line, certainly if there's a delay or if a specimen is compromised and the diagnostic results are incorrect because of that. So there's certainly more severe implications with this. And I think that's where the learning comes from, and the importance of looking at potentially low harm events or infrequent events that have, again, the potential to be more severe. So, and, you know, I'd love to do this kind of in-depth analysis on all of our harm types in multiple different ways. Perhaps we can do some kind of data summit for our PSO in the future. And when we have an evaluation go out after this call, you'll have an opportunity to provide any feedback on that as well. But that's kind of where my brain's going with this. But our next steps, and this goes for all of our analysis, not just this that we're discussing today, this particular analysis, but all of our analyses, we're going to examine if this pattern holds true. We know that we found this within our that 3-month period where we saw the big decrease, and it drew our attention, and we began eliminating some of the noise in the data and figuring out what we can learn from this. So we're going to keep examining that similar pattern across different time periods to see if we're seeing similar things. And we also have already begun narrowing down within this data which hospitals are being impacted by this, who is submitting this data, which systems perhaps are submitting this data, so that we can then reach out and get a better understanding of the issue and figure out, do we need to convene our members in a forum around this? Are we seeing this in a more widespread capacity? If it's the tubing system, the pneumatic tube system, is it a certain manufacturer having to do with a certain component of it? So how can we then bring our members together to talk more fully about this? So again, it may warrant a safety alert. And then the last thing I'll say about this is that we incorporate all of this moving forward into what I'm kind of calling our PSO's learning system, which is basically a stored library of data queries and indexes that allow us to then semi-automate the system moving forward. We can now run this exact same type of analysis across different time periods, or if somebody reached out to us and wanted to know more about this within their data, we could then run the same analysis for them. So we're kind of continuously learning. And the last thing I'll say about this, and the point I really wanted to illustrate with this analysis, is that it all begins with you all as a PSO. We collectively are the Keystone Center PSO. And so the more data you can provide to us, the more analysis like this we can do. But also, and I mentioned earlier, a lot of our members throughout the year reach out and might draw our attention to something like this that we may not originally see at the higher level. If it's a low frequency type of adverse event that might not cause a major spike if we're looking at 30,000 different event reports. But if members reach out and say, hey, we've been having this issue, can you take a look in the data and see if, you know, other systems or hospitals our size are struggling with this, et cetera. And a lot of times that leads to a gold mine of analysis and lessons learned. So please do continue providing your data to us, and we'll continue to partner with you and engage with you on analyzing that and bringing the lessons learned to the broader PSO. So just wanted to quickly run through some updated control charts as we're still talking about data here. Last year, I provided an update with the trended data we had at the time on a few different adverse event types where we saw statistically significant increases or decreases as were in the surgery or anesthesia bucket right around when COVID started, at least within our region. So that would have been spring 2020. And so I've updated those again with the same controls and the same average. We used a 20-point baseline for the calculating the upper and lower control limits. And you can see with, we're looking at here is HAI. So this is the reported proportion of HAI adverse events across a several year time span. You can see sort of that spike around early 2020 when the pandemic first hit. And then we sort of had this elevated level, even though it ebbed and flowed on this elevated level of reported HAI, which has since kind of gone down and sort of resumed, albeit still volatile, seemingly, but kind of resumed a pattern within the upper and lower controls. So we'll continue to examine this and take a look at it. But again, because of the data lag, this data is just going through August of 2021. When we look at pressure ulcers, similar type of trend, we saw a major increase around March, April of 2020, and then a major decrease. And then it kind of went up and it sort of sustained this new average. So I think it's around the time where we're going to calculate a new average, new baseline, move those control limits to see if this is a new normal within sort of our data submission and what we're seeing, or if potentially it will kind of go back down and maybe resume a pre-pandemic range, if you will, in terms of those control limits. And then again, with the falls adverse events, similar story as pressure ulcers, a big spike around early 2020, and then it kind of got a little bit lower and sort of played around within that range, kind of tiptoeing the upper control limit, going up and down. And that one continues to ebb and flow. So again, we're going to continue as data comes in and as we have a good sample size and a good denominator as the months go on, we'll continue to recalculate these and continue to see what we can learn from it and drill down, similar to what we did with that device analysis exercise. So shifting a little bit in terms of worker safety, which is a major component of the PSO and the work we do, certainly patient safety is the data world that we live in. But worker safety has major implications for patient safety, as you well know. So just a quick update on what we're doing within this scope of work. I'm very pleased to announce that we have sort of revitalized a long-standing relationship with Blue Cross Blue Shield in Michigan. They're providing us with significant funding to tackle a few different scopes of work, including opioids and maternal health, but also worker safety. So we have dollars now that can back this up. And our PSO is helping to carry out this work and spearhead these efforts. So what we're doing right now is examining the OSHA data, and we're also looking at doing a cost analysis with this. So that allows us to look at recordable incident rates and sort of those 5 major buckets of harm in terms of violence and slips, trips, falls, and musculoskeletal disorders, but also which are the costliest, certainly in terms of days away from work or put on restricted duty for the staff, but also the cost of supporting those staff with care that they may need, and then getting them back to work or having a temporary replacement or sometimes a permanent replacement. So we're taking all of these factors and sort of looking at them together to best inform our next steps moving forward. With this program, we'll begin in fall of this year. So our early analysis, as we're looking at the recordable incident rates and the cost, data that we have access to. Our early analysis is telling us that within our data set, everybody who has submitted this data to us, that the highest cost staff harm is specifically related to patient handling and mobility. And so injuries sustained because of that, many times musculoskeletal in nature. But there's a lot we can do with this in terms of using the BMAT or taking inventory of the lift equipment that's available or not available, or what is the culture of using that lift equipment. So there's a lot of ways we can tackle this. We also know that the most frequently occurring type of staff harm, but not necessarily the highest harm severity, are sharps injuries. So there's a lot that can be done for safety in terms of mitigating and preventing sharps injuries within our member organizations. And then a major factor as well is member interest. So all of these topics certainly need to be addressed and warrant attention and resources and time. But violence is one of the, on the lower end, I should say, in terms of the rate, the OSHA recordable incident rate, but it is of highest member interest. And this is from talking with our members, one-on-one phone calls, focus groups, committee meetings, all kinds of stuff, is that violence. And I will mention too, that this refers to physical violence, but also verbal aggression and that mental health and psychological safety aspect of staff harm as well. So we're taking all of these variables, and this is helping us make our plans for next steps moving forward and rolling out those interventional pieces, which we are currently in talks with endorsed business partner organizations of the MHA. We're talking with third-party vendors and subject matter experts to figure out what will these dollars get us? How can we realize success and improvement in worker safety across our membership with this funding? And I will mention too, the last thing I'll say about this is we will have a focused effort on those members who may not, outside of this funding, be able to afford something like an on-site violence risk assessment on their campus grounds, who would not be able to afford that. So we're taking a lot of different things into consideration moving forward with worker safety. And then you will be hearing later today from Dr. Brian Sexton. We're very excited to have him come and speak to everybody. As many of you probably know, we are currently enrolling staff, any healthcare staff, clinical, non-clinical, doesn't matter, any of your staff if you're in the state of Michigan or if you are a PSO member. So all of our Indiana friends, this is extended to you and all of your staff as well. This is a well-being program. It kicks off March 29th. There will be more information later during Brian's presentation, but the QR code is there, so you can go ahead and register right now. And we will also be showing that QR code during our breaks today, so you'll have another opportunity to look at that more closely. In terms of the Speak Up Award, this continues to be a fantastic program, continues to garner a lot of interest within our membership, certainly because it is open only to our members, but it's of great interest to organizations outside of the PSO who want to learn from us and sort of figure out how they can implement something similarly. So all time, we're going into almost our 7th year here with the award program, more than 1,000 nominees, well over 1,000 nominees, more than 70 PSO member organizations have nominated staff. We've awarded 24 quarterly winners, 6 annual winners. According to our cost analysis that we published a few years ago, this has saved across the continuum of care millions of dollars, and more importantly, most importantly, affected thousands of lives within your organizations just because your staff spoke up and prevented harm to patients or other staff. So thank you very much for those organizations who participated. We've listed you all here just as a call out. Thank you so much for nominating staff. It's just a major demonstration of your culture and your leadership in this work. And for those members who didn't know about this program or you want to know more information, you can certainly reach out to us. These nominations are on a rolling, ongoing basis. You can nominate any staff at any time. Just a look at things to come this year. So we just completed our most recent culture survey cycle in 2021. So we're currently in an off year in 22, and then our next opportunity for members to survey will begin in 2023. So if you're interested, please do reach out to us. If you're planning on doing a culture survey, we offer that as a benefit of PSO membership. But right now, we're working on analyzing the data from last year. So we're just now getting all of the results in roll-up reports and different things, and we will be sharing that information with you, the lessons learned, what we're seeing with burnout and emotional exhaustion. We'll be sending that out in member communications and potentially putting together some webinars as well. I mentioned the Well-Be program. We're also continuing to do virtual safe tables, sending out safety alerts, again, using that power of data and data analysis to drive that work. I mentioned the Workplace Safety Collaborative being spearheaded by the PSO and the Speak Up program. We are also continuing to send out those biannual PSO engagement reports, so you can expect the next one to be sent to you in June or July of this year. And then finally, the RCA aggregate analysis and subject matter expert analysis, I should say, with our RCA review committee continues to be a major benefit in terms of that in-depth analysis, pulling apart RCAs and all the supplemental information within them, and then distilling that into a 1 to 2 page summary and alert that can then go out to our members. And so I just wanted to take a second and thank this group of individuals who served last year as our RCA review committee. It's just fantastic work. They take it incredibly seriously. They do their homework, de-identify these RCAs on a particular topic that were submitted over the last few months. And we look at them and critically think about them and ask questions, and we utilize the RCA squared methodology and then share what we learned with the rest of the membership. So huge thank you to this group. The last, coming into the close, I should say, of my presentation here, just wanted to mention that we continue to be a leader in certainly safety and quality within the Keystone Center, but absolutely within our PSO, an authority on patient and staff safety, not just within our PSO membership, but nationally as well. So we have a number of publications in the work, a journal or article on the Safer Together National Action Plan you may be familiar with. We have a book chapter coming out in a book called Patient Safety, and that's on our MHA journey of high reliability. And then the Speak Up Award, again, this model continues to draw a lot of interest nationally. The Virginia Hospital Association has fully adopted this process, as well as the Washington Patient Safety Coalition, and they are currently trying to work with the Washington State Hospital Association on a similar relationship that we have with our members. The Advancing Safe Care Award, just an FYI, I wanted to call this out. It's a fantastic program, honors healthcare teams who demonstrate commitment to quality care across diverse socioeconomic populations. So I've gone ahead and linked that, and nominations are accepted through March 25th. So with that, we ended right on time, 9:45. Wow, I don't think that's ever happened. That's fantastic. I see one chat question. Oh, interesting trends. I'll take a look at that and respond via chat. So just for the sake of time, we can move forward.
I'm honored to have the opportunity to speak to all of you today. As Clarence mentioned, I'm a clinical pharmacist by background. I have a little bit of a varied work history in that I've worked in the acute care setting, ranging from critical access hospital to community hospital to a tertiary care academic medical center. I also spent a number of years in academia, and as a clinical faculty at a College of Pharmacy, had a clinical service with the Visiting Nurse Association in the Albany, New York area. So we were doing home visits on immediate post-discharge patients with heart failure and other things. I like to say we were doing med rec before med rec was cool. And then I found my way into the QIO world and started working more on the policy and the state level and national scene for drug safety in general when Medicare Part D started. And that's what led to my interest in anticoagulation. I will say up front, I am not a anticoagulation therapy specialist. I never practiced in that capacity. But the work that we did with iPro, with CMS, with others on anticoagulation safety is what really led me to this point. So what I'd like to do today, and just to confirm that slide did advance for you, Adam?
Yes, it did.
Perfect. I want to give you a bit of background on kind of the state of anticoagulation across care settings. And by doing so, put in perspective the importance of these drugs, how widely used they are, how frequent the opportunities are for issues and errors and harms, avoidable harms, and then introduce you to Anticoagulation Forum in detail so that you might be able to tap into the resources that we make available nationally and across North America to drive improvements and to basically help providers, health systems accelerate their paths towards stewardship and improved care systems and things around anticoagulants. So at a high level, if you're not familiar or don't give a lot of thought to specific drug classes, anticoagulants are far and away the class of drugs most frequently associated with adverse drug events, prompting emergency room visits and hospitalizations. I'm going to go into this in some more detail. And that's on the outpatient side, but also on the inpatient side, errors and avoidable harms are extremely common, unfortunately, in the acute and residential care settings. I was on a P&T committee at that academic medical center years ago on the subcommittee that did, adverse drug event reports and incident reports and all that. And 30 years ago, we were struggling with problems with heparin and errors and dosing. And lo and behold, here we are 30 years later, and we still are. Care transitions are very error prone. And as I said, I spent 8-9 years doing home visits. And as patient length of stay on the acute care side shortens, as the complexity of care increases in the acute care setting, and as patients transition out through rehab and to home care, the opportunities are everywhere for mix-ups. And with anticoagulants, more so than many of the other drug classes, an error in either direction, either overuse or underuse, can be catastrophic for patients in the form of bleeding or thrombosis. Quality measures, and I'm sure you're all very in tune to what quality measures apply to hospitals and other care settings. Unfortunately, they're suboptimal in a lot of ways. I can refer you to a document. We did a gap analysis of existing quality measures relating to anticoagulants, and while they serve a purpose, the use of anticoagulants and the harms associated with them are so varied that I think it makes it difficult, especially in the acute care side, to come up with quality measures that are universally applicable, that are robust, and do all the things that we need them to do. So it's very hard to come up with a single quality measure or a small number of quality measures that really get at the heart of the many varied things that can go wrong and the areas where there's a lot of high variation in quality of care practices. I'm going to go into a little bit of detail on how the use of anticoagulation and the complexity of the regimens is increasing. And I think that might be surprising to some of you if you're not in the field as to what's been going on over the last 10 years. So it's not the environment that we had 10 or 15 years ago, for sure. And there's a lot of published evidence that organized services, stewardship-like services around anticoagulant management or hemostasis and thrombosis management are incredibly impactful, but unfortunately, they're not the standard of care nationally. You see them in the academic centers, you see them in the front end innovative health centers and systems, but they're not widespread enough to bend the curve in harms related to anticoagulants. So driving into some more detail. So this is a little bit from a paper that was published 10 years ago in the New England Journal of Medicine by Dr. Dan Budnitz and Nadine Shihab at CDC. And what they do is they have a national surveillance system that's part of a bigger national surveillance system for device-related harms and things like that. But they have a representative sample of hospitals and they have trained abstractors looking at ER encounters. And several years ago, a decade or more ago, they started collecting data on drug-related harms as they presented to the ER. And what they found is that 4 drug classes were implicated in 67% of hospitalizations relating to adverse drug events. So of all the hundreds and hundreds of drugs that are out there, 4 drug classes accounted for 2/3. And lo and behold, warfarin, the only oral anticoagulant widely available back then, was number 1 with a 3-fold higher rate than insulin. And then the next closest class was antiplatelet drugs, which are very similar, without going into great detail, to the anticoagulants, and diabetes agents, other oral diabetes agents. So it becomes really obvious very quickly that drugs that affect coagulation and blood glucose are the main drivers of drug-related harm. So if we as health systems are going to address preventable drug-related harms, I think it makes a lot of sense to have systems in place that focus on these drug classes. And I'm a little biased towards the anticoagulant one, as you'll see. So this is a table from that same paper from Dr. Budnitz from 2011. And you'll see that warfarin accounted for 33% of the adverse drug events related to hospitalizations, oral antiplatelet drugs, another 13%. And then the bottom 2 in the blue box, I called out on purpose because they're drug classes where there is a lot of national attention and a lot of movement. So antibiotics, interestingly, are an entire order of magnitude, 4% versus the cumulative 40% with the anticoagulants of the harms, although we now have national systems for antimicrobial stewardship, which you're all familiar with. A lot, if you think of what goes on in antimicrobial stewardship, I would argue doesn't necessarily focus on the antimicrobials as much as a lot of the other catheter-related processes and infection control. So I think they've done a bit of a disservice calling it antimicrobial stewardship. There are aspects of the prescribing and the drug selection and use that are important, of course, but I think of it as infection control in a more broad sense. So antibiotics already have a system in place. There's national conditions of participation for antimicrobial stewardship for hospitals and nursing homes, things like that. And then we're all familiar with the opioid epidemic and the harms that are associated with illicit opioid use. But as you'll see from some of this data, the opioid epidemic is largely affects younger populations, whereas your hospital acute care populations are typically older patients. And you'll see some of the data showing that opioids themselves are not, at least therapeutic use of opioids is not as big of a concern among the older population, particularly the very old, that you'd see in an acute care hospital. So that's 2011. Fast forward to the fall of 2021. Dr. Budnitz is at it again, and Dr. Shihab, and they both have served as ex officio members of our board, and they've been very supportive of our work at AC Forum. But every 2 or 3 years, they run their data again. And what they found in this past publication was, as they break it out by age groups, I know there's a lot of text there, but basically what they showed is that the top 2 drug classes for patients above 65 that are contributing to ER visits and hospitalizations are anticoagulants and diabetes drugs. And among the patients 45 to 64 years old, they're anticoagulants and diabetes drugs. So here we are 10 years forward, and those 2 drug classes are far and away the ones that are causing the most drug-related harms in those older populations. And then if you look at the younger population, this is where benzodiazepines and opioids, illicit non-therapeutic use, come into view. And then in the younger population is where you see poisonings and therapeutic antibiotic related adverse events. So it's really very obvious from the data. They've published 4 or 5 of these papers that adverse drug events are an age-related phenomenon, that the younger you are, pediatric patients have a certain type of adverse drug events. Adolescents and young adults have another, but as you get into what I'd call the acute care population, the 45s and ups that require hospitalization, that have multiple comorbidities, that have these complex therapeutic drug regimens, anticoagulants and antiplatelet drugs are far and away the biggest drivers of harm. And there's quite a bit of research showing that many of the adverse drug events associated with these drugs are preventable and through high quality systems. And I'll share some of that information with you as well. So this is a breakdown of one of the tables from that 2021 Budnitz paper. And what I've got here is limited to the patients over 65. But remember the one from 2011, it was warfarin, antiplatelet drugs. Now what we've seen in the last several years is the advent of new, what we call direct oral anticoagulants, the DOACs, which are apixaban, rivaroxaban, dabigatran, which is not listed here, and edoxaban. But these are drugs that came out over the last 10 or so years that were intended to replace the notoriously difficult to manage warfarin. Warfarin is an oral anticoagulant. It's been around for 50 or 60 years, requires very close therapeutic monitoring, very customized dosing at the individual patient level. And as we saw in the earlier data, caused a lot of those patient harms. So they came out with these direct oral anticoagulants that are much easier to dose, simple dosing regimens, no routine blood level monitoring required. And they have been shown to be as effective or in some cases more effective than warfarin. And they have been shown in large trials to have a lower rate of life-threatening or serious adverse drug events such as intracranial hemorrhage. But what you see now in this table is that warfarin still accounts for 20% of the adverse drug events. Apixaban and rivaroxaban, the two biggest, most widely used DOACs, now account collectively for over 14%. So the DOACs, if you lumped in the couple other ones, the Pradaxa, dabigatran, and edoxaban, if you lumped them in with apixaban and rivaroxaban, that would put them as the number 2 drug class. Warfarin is number 1, and these drugs is number 2 drivers of adverse drug events in the elderly. And then if you lump in clopidogrel, which is an antiplatelet drug that used in acute coronary syndromes and in people with peripheral artery disease, and you throw in over-the-counter aspirin, you've now got 50% or so of the adverse drug events driving seniors to the ER nationally, and about 50% of those patients are admitted. So if you didn't have an appreciation for this before, you can realize now that the environment's changed a lot where we have new drugs, but we're seeing the same trend, that anticoagulants and antiplatelet drugs. You'll also see that some of the diabetes drugs are still in there. Insulin, metformin, glipizide are all diabetes drugs. So they're still there. Same story. Lisinopril is an ACE inhibitor, is a drug for blood pressure lowering that's commonly used in patients with diabetes. And then very down at the bottom of the list, you see oxycodone, which is obviously one of the opioids. And you can see as you put them in comparison, it's an order of magnitude difference in this population between opioids. And I don't see any antibiotics on the list. So as we say, we've got antimicrobial stewardship, we have all these systems in place, and we have an opioid epidemic, and not to diminish the impact that illicit drug use has had on our young adults across the country. But if you are looking at older adults who are medically ill with complex comorbidities and drug regimens, the anticoagulants are where I think we need to put a lot of attention. So hopefully I didn't overdo it on that, but I wanted to give you that appreciation. So going back to this overview slide, if that didn't convince you that they're the most common drug causing ER visits, I can send you some more information. Also on the acute care side, I touched on it earlier that errors in the hospitals and in nursing homes and other settings are very common as well. The literature is not as consistent. It's just very hard to get consistent reports, as you've had them know, detailed, granular, consistent reporting. But I think we all know from incident reports and root cause analyses and never events and things that the errors and the harms in the acute care setting are very common. Care transitions, as I mentioned before, are extremely risk prone. And the new drugs have added to the complexity, and I'll get into that. Quality measures and administrative oversight requirements are still suboptimal. And so I'm going to jump ahead and get into why the complexity, because I think this point may go unnoticed to people that aren't, in anticoagulation, in thrombosis and hemostasis. So when we only had one drug to worry about, warfarin, we did a poor job with it, but only had to worry about warfarin. And now you've got 4 additional oral anticoagulants on the market, and they're all unique. The dosing is different. Their indications for use from their package labeling from FDA is different. They have different drug interactions. They have unique characteristics. They're different drugs. And they also added the complexity of confusion between drugs if clinicians aren't very familiar with the drug. So for example, you've got a dose of 2.5 milligrams of apixaban is a full dose for somebody with renal insufficiency. But the Xarelto folks just came out with a 2.5 milligram tablet, which is a low dose for that drug for peripheral artery disease. So we're already seeing errors between drugs because a DOAC that's dosed 2.5 milligrams now could be very wrong. So they're not interchangeable. Expanding indications for use. So an indication would be an approved use of the drug. So whereas warfarin was used largely for thrombosis, like VTE, pulmonary embolism, for people with heart valves, and for people with AFib, what you're seeing now with these drugs is that with the investment of these competing drug companies and things, is that they're seeking expanded indications for use. So whereas years ago, you may have only stayed on warfarin for 3 months after it provoked blood clot in your leg, what you're seeing now is studies showing the value of extended secondary prophylaxis in VTE. So people are on it longer on lower doses. Peripheral artery disease is now a new indication for anticoagulants where warfarin was never used there. So clopidogrel was the antiplatelet drug, but you're seeing now a major campaign from one of the drug manufacturers to use anticoagulants in peripheral artery disease at that novel dosing level in combination with aspirin. So it gets very complicated as to the number of patients that are now eligible has gone up due to these increased indications for use. And also as you increase the age of the population, you get more patients eligible. So it's just more drugs, more indications, more eligible patients. And it makes for complexity for clinicians and for health systems that can't be managed one case at a time. You need systematic management to do a good job at these, I think. Implanted devices are the other thing. As you start getting more heart valves, breakthroughs in heart valves, left ventricular assist devices, left atrial appendage occlusion devices, which are these devices to help block off a portion of the chamber of your heart to reduce your risk of clotting or stroking from AFib. All of those involve some use of antiplatelet or anticoagulant drugs. And as they come out and they compete, and as they enter the market, it adds to that level of complexity. So depending on what your hospital's doing and what kind of patients you're seeing, it gets really complicated. Complex patient characteristics. Obesity becomes a huge issue, whether it's prophylactic doses of heparin for patients who are medically hospitalized, dialysis patients, renal replacement therapy. All of these involve anticoagulation at some level for and management of the anticoagulants for patients who are already on them, but then possibly introducing anticoagulants to patients who were never anticoagulated before. And then to top it off, multiple reversal agents or antidotes have come to the market. Some are specific for specific direct oral anticoagulants, and you'll also see strategies that involve the use of blood factors, clotting factors that are typically used for thrombophilias and things like that. They're remarkably expensive. If it's a bleeding event, they're typically needed in an urgent manner. So policies and procedures and appropriate management and preparation of these drugs is really, really important. And you saw from the figures that I showed from those Budnitz papers, what are the drugs most likely to cause an adverse drug in an ER? Bringing a patient to an ER, it's anticoagulants, and what agents do they need to understand and have policies and procedures and experience with? It's these reversal agents for these severe bleeds. COVID didn't help, as you all know, but COVID is terrible overall. but COVID is very much a thrombotic disorder. Even though it's an infectious disorder, the harms that are associated with poor outcomes are pulmonary embolism and hypercoagulability. And then there's adverse events that have been associated rarely with some of the vaccines themselves, and those were thrombotic in nature. So even COVID is to a large degree a thrombotic disease. And so if you're dealing with a large population of patients with COVID, which I know Michigan did in multiple occasions, multiple waves, it is the management of anticoagulants prophylactically and in the treatment setting are really, really important. And then the literature is evolving like crazy. And I'll show you a website that we have. So published best practices, published studies, on the topic of hemostasis and thrombosis. It's never ending. So for clinicians or health systems, it's beyond what one person can keep up with, and we need systems in place to make sure the best practices are followed. So a lot of information there. And this is just a summary. This is a draft of a document that we are now waiting for the final copy from a professional graphic design firm. So I had a pharmacy intern who put all this together, but I think it's wonderful. But it shows real quickly some of these high areas where there's gaps and where systematic processes have made a difference. These are all published papers with statistically significant findings on both sides. So inappropriate DOAC dosing, as many as a third of patient dosing of those new drugs on the outpatient and acute care side is incorrect and is associated with increased adverse outcomes, whereas a good stewardship program can improve the dosing of those agents remarkably, whether it's through an order set or a policy in the hospital and pharmacy changing doses. Suboptimal adherence. If patients stop taking these drugs, they're at risk of strokes. And it's been shown that adherence programs do a remarkable job of increasing patient adherence to those drugs. We just heard of a national pharmacy benefit management company that decided to save money. They changed their formularies for some of their commercial plans to no longer include all of the DOACs except for one. They're forcing everyone to switch. And if patients go in and say that all of a sudden the drug I used to take for $20 or $40 or $50 a month is now $900 and have to go through a prior auth, you can see how this is going to be a problem. Inappropriate aspirin combination. So we talked about how aspirin and clopidogrel, those antiplatelet drugs and anticoagulants, are all on the top list there from the Budnitz papers. Using them inappropriately together dramatically increases the risk of bleeding and major bleeding, yet has no documented evidence of reducing thrombosis. So a third of the time to a half of the time, your patients who are on anticoagulants are taking aspirin inappropriately. So if they're on a combination, 30% to 50% of the time it's inappropriate. There are cases where they will use both, but unfortunately, about a third of the time, there's no documented reason why they need to be on aspirin, and it's just driving up the risk. Warfarin management over the years, decades, has been remarkably terrible and hasn't changed much. There are centers that do a remarkably good job managing warfarin, and many, many don't. I know from research we did ourselves in nursing homes, you want your time in that therapeutic range above 65% for the average patient. We did an assessment of nursing homes across New York State and found they average around 35% of the time in range. They're out of range 2/3 of the time, which increases bleeding risk and thrombotic risk. I did see the paper just came out. It's in the Joint Commission Journal of a national patient self-testing program, one of the big vendors that does patient self-testing. They average 68% of time in therapeutic range with a population like 20,000 patients during COVID. So there are systems in place that can do a really, really good job. And then there's a lot of one-off small practices that do a remarkably poor job with warfarin management. Bleeding management and utilization of clotting factors. As we said, these reversal agents are very expensive. They're very complex. And oftentimes they're not used properly, but good programs can reduce inappropriate prescribing by a lot. And programs at big academic centers where they use a lot of these clotting factors, not only for reversal of anticoagulants, but also for thrombophilias and hemophilias, they've saved millions and millions of dollars in costs by managing those products well. And that funds a lot of the other pharmacy and clinical activities to manage the other drugs. The other aspects of anticoagulation management. And then heparin-induced thrombocytopenia is another one of these conditions that, although it's rare, drives up length of stay, high morbidity, high mortality, and good programs do a good job at improving the management of that condition. And then I didn't include data here on peri-procedural management and the LVADs and many of those other things, but there's a lot of evidence showing that the quality of care is highly variable, lots of gaps to close, and good programs can improve those outcomes. All right, Joint Commission, as I said earlier, took notice of those Budnitz papers and other evidence and implemented, I think in 2008, the National Patient Safety Goals and included anticoagulation there. And warfarin was the main focus. Warfarin and heparin were the main focus. But then a couple of years ago, they updated these now to include the DOACs. So if you're a Joint Commission accredited hospital, your National Patient Safety Goal now includes management of the DOACs. But they also included additional, what do they call them, the EPs, evidence of performance, to include peri-procedural management and some other care transitions and things. So Joint Commission themselves is starting to drive improvements in the management of these drugs and required of their accredited hospitals. So covered a lot of ground. I'm going to stop and look at that chat box. Or Adam, if you could see, is there anyone have any questions on kind of the background before I jump into AC Forum?
Yeah, we actually did have a question come in, Darren. So the question is there data showing high fall risk elders suffering bleeds from being on anticoagulants? I see this in the hospital in the very old. We need to question the use of these for prevention of stroke with the risk of fall injury risk.
Yeah. So it's a very complicated situation, and there is some published evidence out there that the risk of a patient being hurt, a person who is eligible for anticoagulation, has a higher risk of harm from a stroke or thromboembolic event if taken off therapy than having a severe harm event due to the fall while on the agent. But I understand that as you get into the very old, the 80s and above, that there's a lot of room for clinical judgment and individualization. So I can follow up and share some papers if you'd like on that. But my understanding of the literature, and I haven't looked at this recently, is that although it's a legitimate fear of a clinician, the fear of the harms associated with not treating tend to outweigh the harms associated with those fall events. And unfortunately, I don't want to go into great detail, but the risk factors for having a stroke, let's say in the AFib patients, are the same risk factors for bleeding. They overlap. There's a risk score, the CHADS-VASc, which calculates a patient's risk of having a stroke with AFib, and it includes age and sex and diabetes and other factors. And the HAS-BLAD risk score, which is a risk score for assessing or estimating a patient's risk of having a bleeding event, has some of the same risk factors. So as they get older, you're always weighing those competing risks. But I'll follow up and see if I can find a good solid paper that lays that out for you folks.
Great. Yeah. Anything that you feel would be valuable and you'd like to share after the call, we can certainly post that to the online community where all of the slides.
I'd be happy to. All right. So we'll segue over into anticoagulation form. Is that it, Adam? Was there any other questions at this point? Okay, good. So about anticoagulation forum. So we are the largest non-for-profit professional society of anticoagulation specialists in North America. We have around 13,000 members between largely the US, strong contingent of Canada, and a number of patients globally, clinicians globally that are members of our organization. We originated over 30 years ago. Dr. Jack Ansell, who is still involved with the organization, was a physician, hematologist from Boston, who realized that there was no professional society in existence at the time for clinicians who manage warfarin. We started out very much as a Coumadin clinic professional society and started meetings and resources and things around that one drug, largely on the outpatient side. And that was our origins. And we've now evolved into an organization of 13,000 members spanning all care settings, all of those agents, and increasingly all those complexities across the board. So our mission: improve the quality of patient care is foremost around those drugs. Educate and empower current healthcare providers. So education of clinicians. That was our basis when we started with warfarin, and is really our focus now, is the educational slant. Advance the training of future experts. We do have a program named after Dr. Ansel, the Ansel Fellowships, where we provide funding for physician fellows in vascular medicine. And we have a number of, I think Michigan might be one of the sites, the University of Michigan. So we're training future physicians, because we think that's really very important to have those champions, those well-trained clinician leaders in the space. And we are right now collaborating with Brigham and Women's Hospital in Boston to advance a pharmacy residency, so a postgraduate residency for pharmacists in thrombosis and hemostasis. So we're really invested in providing education to current clinicians and trying to bring forth the next generation of leaders in this space. We're doing a lot more advocacy work and connecting with big organizations like the PSOs, but also working, trying to engage FDA, trying to engage CDC, CMS, others to advocate for best practices. And then recently started a new committee that we call the IDEA Committee, focusing on inclusion, diversity, equity, and allyship. And what we're hoping to do is develop partnerships with organizations in that space to address disparities in care for minority and underserved populations. So we're cultivating relationships with several national organizations, such as the National Minority Health Association. Care disparities are bad enough in general when you think of these drugs and what they're used for. We know that certain minority populations have higher risks of atrial fibrillation and cardiovascular disease. But through one of the discussions I had recently with the National Minority Health Association, the topic of peripheral artery disease came up. And so these drugs are now being used and marketed for treatment of peripheral artery disease, and the evidence shows reduced severe cardiovascular events and amputations. And unfortunately, the minority communities, underserved communities, are at higher risk of experiencing those adverse events, including amputations and things. So we really want to start advancing our efforts in that area to close those gaps, increase access to training of clinicians in those communities, and highlighting the gaps in the quality of care so that resources are directed to where they need to go. All right. We are an odd duck among professional organizations, that we are multidisciplinary by design. Dr. Ansel, when he first started the group, decided we need physicians, pharmacists, and nurses working together. And so our board is multidisciplinary, and practically everything we do is intentionally designed to include pharmacists, nurses, and physicians at some level. It's really kind of neat because everyone's on a first name basis. There's none of the hierarchy of professions and things that goes on within our organization. And the other thing is, as we interact more with other professional societies like the pharmacy organizations and Society of Hospital Medicine and the others, those organizations, and they're all wonderful, have the barrier, kind of a baked in barrier of, well, we're advocating for pharmacy. I'll pick on the pharmacy organizations. It's like, well, I don't care. I want patients to have really good care. So if you're in a rural community and a nurse practitioner is doing a great job with Coumadin, I'm cool with that. So we're a little bit odd that way, that we're multidisciplinary, but I think it gives us a perspective that's very unique. We have an active board of nationally recognized experts. You can go on our website. So we've got these pharmacists, physician, and nurse thought leaders from across the country who are not only on the board, but they've got their sleeves rolled up and they're involved in many of the projects on a regular basis. So a really highly active board that does a lot and contributes greatly to the organization. And then the other odd thing is, I think we're in all of your price ranges as an organization because membership is free. So Dr. Ansel desired from the beginning that people shouldn't have to pay to have access to good education around this topic. So much of our educational content is available free of charge, and many of the other things I'm going to show you in the next couple of minutes are available free of charge as well, including continuing education credits. And the only thing we really charge for are things that we're trying to draw the line between education being free and training. When we do formal trainings like our boot camps and conferences where there's huge costs involved in pulling them off, that's where the only areas where we tend to charge for things. I went back to our website when I was putting the slides together for this, and I'm going to try to bucket these resources into three categories: kind of the website and membership bucket, centers of excellence, and then anticoagulation stewardship. So our website, I'm going to jump around a little bit, but this is kind of fun, and I'm hoping, and in the slides, I put hot links in all the slides of Adam, if you can disseminate the deck, everyone should be able to jump and navigate to all these things. So we've got a number of cool things that we do. We've put together a number of guidance documents, so expert guidance from our board. The most recent one is a COVID from 2020, but we have a new updated version that's being submitted, if not already, to one of the journals. So a very practical question and answer format for around the use of anticoagulants in COVID, commentary on national patient safety goals, reversal agents. We put out a guidance paper on the use of those antidote reversal agents. So these are very practical evidence-based guides that you can take and run with. And they're all tend to be in these question and answer format to really help you navigate and get to the answers to the questions you're looking for. Order sets. We put some time and effort into developing these structured order sets on key topics to make this resource available so that smaller hospitals that don't have the in-house expertise or don't want to take we don't want them to need to take the time to start from scratch. I don't say we don't want that they don't want to take the time, but we want to jumpstart the hospital's ability to implement and develop their own order sets. So for example, which one do I want to pick? I guess let's do this PAD one because this one's new. So basically, these are all structured very much alike, where we're giving you all of the content that you would use to develop an order set at your own facility based on the available evidence and based on the clinical expertise of the subject matter experts that were involved in producing it. So the purpose, inclusion criteria, high-risk features. This is for peripheral artery disease, patient selection. So very bulleted, very concise, and basically you could either adopt this as is or modify it to meet your needs or based on your own local expertise to jumpstart getting policies and procedures and order sets in place there at your facility. One of the most exciting things, I think, and this is really very unique, I think, among the professional organizations, is we have these monthly webinars, approximately monthly, which are free of charge. And the topics and the speakers are typically the authors of breaking landmark trials and influential papers. So approximately once a month, we've got a committee that reaches out as we see these papers come out and reach out to these speakers. We'll have over 1,000 people nationally on these calls. We'll solicit questions and answers in advance that we can review and present to these researchers who publish these papers, and then have live Q&A during the calls at the tail end. So anybody who participates in these free webinars basically has access to the authors of the papers and a panel from our board that leads the discussions. There are recent ones just last week, DOAC, claims-based observational studies, huge paper showing differences in bleeding and thrombotic events between the DOACs based on a huge claims-based study. Perioperative management, antithrombotic guidelines were just updated back in the fall. So any of these key topics as they come out, you can have your clinical staff, dial in for free, submit questions in advance, and get CE. And then they're all enduring on our website as well. So if you've got staff that need education, or if you want to require, which I think would be a great idea, a certain amount of continuing education credit for pharmacists, nurses, physicians in the space at your facility, if you want them to be required, these are enduring and they can go on whenever they want and get access to those programs. Educational programs. We have some other ones around topics. I know we have a new PAD training program that's free with CE. that's available on our site. So if you're, have people exploring starting a PAD clinic or any of these other topics, or VTE, PE or PERT programs, things like that, those programs. So they're not just a one-off, they're more modular, longer programs. All right, this searchable resource center, I'm probably giving you all vertigo, but this is really something that I think has great value to hospitals and clinicians if they're aware of it. So this is basically a curated library of resources on any number of topics in the anticoagulation space. So if you're interested in peripheral artery disease and you're wondering what's going on, where's the latest literature, what tools are out there from our other members and things, you just search for PAD and you've got these things there. You can search by individual buttons if you're worried about what's going on with valves. There's all the guidance and updated resources there on valves, peripheral artery disease, acute coronary syndromes, all of these things. And again, it's all searchable. We've got a committee that routinely culls the emerging evidence and adds new resources onto this site. So this is all free, open access. So if you've got, patient events or area of concern through talking to Adam and the PSO and saying, wow, where can we go find resources? This is the place to get them, and everything in here is free and it's been vetted by subject matter experts. So we welcome you to go into there. Rapid resources are new, relatively new, and what these are as these hot topics come up, what we've discovered is that people want just really good evidence-based summaries and that they can work with. So we've developed these basically one-pagers with an expert committee that tackles these things and boils down everything into a one-pager. So here's one on these left atrial appendage devices. And what are we doing with antiplatelets and anticoagulants around the use of these devices and things. We've got some on obesity, on a number of other topics that are these critical things. Where do we go? Reversal agents, any of these. So it's a nice summary, quick resource on these different topics. All right. Literature website. This is my baby. So this is something we started just within the last year. And we had one of our board members actually was so thoughtful. He had a PubMed search that he ran every 2 weeks and identified papers that were relevant, and he categorized them by topic and put them in an Excel spreadsheet and shared them with his staff at his VA hospital where he worked. So, well, this is great. We started pushing it out to our members, but it was an Excel spreadsheet. So what we did is we engaged our web designer and took that same data and put it into this interactive dynamic website that is updated every 2 weeks. So every 2 weeks, we run a PubMed query. We're working with a medical librarian at one of the colleges of pharmacy, develop these automated queries. We run the queries, we run them by a team that evaluates the hits every 2 weeks, and then he applies stars to the higher quality, the more influential papers, and continues to include the citations to the others on all of these different topics. So if you have a clinician who's trying to stay on top of the medical literature, this is the place to go. And on the site, you can just click on there. You can see the actual abstract from PubMed. And if you want to go to the actual citation, you just click and it takes you right to the paper and you can access it. So if you need to stay on top of the medical literature, which I think everyone does on this topic, this is a resource that can really save you a lot of time and effort. And then what they started doing is the same gang that was doing the rapid resources started looking at the starred papers that they put in the literature site, and to digest it even further, started putting together what they're calling rapid recaps, which take 4 or 5 of those top papers and summarize them very briefly and put it out there. So if you want to stay on top of the literature, you can go to the site every 2 weeks and look at what's new. If you sign up as a member, you're automatically going to have access to the rapid recaps, and we typically update those, include them in our newsletter and things as well, which gets us to the newsletter. I'll pull over our February one. Giving you vertigo, Adam? No? So if you sign up as a member, every month we push out our newsletter, and it has links to information on our webinars, let's see, the January recording from the previous webinar, the learning series. So anything that we've got coming out or has recently been posted to our website and think is out there, the latest rapid resource, our pharmacy residency. So all of this information and links to the literature. So it's just a great, summary just to get on the email list and get that pushed to you. So that is like a whirlwind of stuff. There's actually a lot more stuff I didn't cover. That's all available free of charge on our website. All is evidence-based, all curated by our subject matter experts and ready for your teams to use if you want to tap into it. The Anticoagulation Centers of Excellence bucket. A number of years ago, AC Forum started this voluntary Center of Excellence program where they created a self-assessment that a clinic can elect to undergo. And it basically guides you through the systematic components that you should have in place to have a high quality, excellent anticoagulation management service. And then I think they revised it several years ago to include acute care side as well. So there's so it's a great resource if you want to drive quality in your anticoagulation management services. The assessment itself, you can access it online and use it as a reference, but it's a nice motivator to have your organization go through the process of achieving Center of Excellence status. And then the other thing we do is once you achieve that, we've started a group called the Innovation Circle. And so we have a special series of events and projects and discussions and things that's limited to that community. We have an online listserv just for the Innovation Circle members that are all centers of excellence. So you can interact directly with other people, and it really is a driver of improvement and collaboration for those centers that want to do that. I will say that we're not the only organization that has one of these assessments out. The Institute for Safe Medication Practices, ISMP, also has an anticoagulation, antithrombotic assessment, self-assessment. That's actually very good. And there was just a paper published this past week of a hospital that utilized that to drive a task force at their facility to show improvement in their anticoagulation management practices. So to have a structured guide, I think is very, very helpful. And then stewardship, I'm going to probably race through this, unfortunately, but I really do welcome you to circle back to this. I mentioned that CDC has been doing these papers for years on adverse drug events, but the upper level, the leadership of Department of Health and Human Services created a document called the National Action Plan for Adverse Drug Event Prevention several years ago. Some of our board members contributed to that. Dr. Nadine Shiab from CDC, I think, led the writing of it. And they identified anticoagulants as one of the top drug classes, again, contributing to adverse drug events, and advocated the adoption of anticoagulation stewardship to really systematically drive improvements. And so that was the impetus for other organizations to jump on board. So FDA funded us at AC Forum to develop a core elements of anticoagulation stewardship guide that parallels the work that's been done in antimicrobial stewardship. I'll show you that. The VA has for many years been a national leader in the management of warfarin on the outpatient setting, and now they're moving at all the VA hospitals, adopting standards for DOAC management and acute care stewardship. So the VA themselves is moving in this direction. Joint Commission, we mentioned the National Patient Safety Goals, and then we're collaborating with the National Quality Forum that's right now developing a playbook on implementing anticoagulation stewardship, and that'll be available late this summer. We at AC Forum decided to go down the stewardship route if we were ever going to, as a decision to move the needle. I think the organization after 25 years realized we do a really good job of educating individual clinicians, but we're still seeing these terrible numbers of adverse drug events, poor quality care. So we see this as a strategy to kind of raise all ships. We did receive this initial funding, a one-year project from the FDA to develop the core elements guide, which is available on our website. It's accompanied by a checklist of key aspects of what we believe constitute a anticoagulation stewardship program. applicable to the hospital or the outpatient side. There's also that gap analysis that I mentioned earlier. That was part of this project as well. So we really dove into where the holes are. If all you're doing is chasing the reportable measures, you're missing a lot of these other things that go under the radar of those measures. The core elements, very briefly, look a lot like the antimicrobial stewardship ones, in that the administrative support, champion, and multidisciplinary teams are really, really very central. We think care transitions specifically needed to be its own core element, and this education and training and competency of clinicians we felt was somewhat different because of the magnitude of the literature and things. So there are some nuanced differences from the antimicrobial stewardship core elements. From our work with other hospitals implementing stewardship, we really see the securing the hospital leadership as being the hardest. Many of the hospitals have the clinicians, the pharmacists, and hematologists and others that have interest and expertise, but to systematize processes across the system, you really do need leadership, carving out people's time, baking reporting of anticoagulation related metrics into leadership goals and discussions. So that's a real challenge for clinicians who want to start stewardship. I'm hoping in speaking to this audience that you see the value of stewardship from a health system perspective. Say, wow, this is a good idea. How do we develop this? How do we resource this to move it forward? After our first year of funding with the FDA, we got a second contract, and we're currently in it. We call it the MIDAS program, where we're doing mentored implementation of anticoagulation stewardship. We're working with 5 hospitals across the country. We're just wrapping up with them right now. And we have a team of pharmacists and physician and nurse experts that have been working with these hospitals to develop and implement stewardship programs in their facilities. And there's a number of other papers that have been emerging. Johns Hopkins just published a paper in one of the pharmacy journals around their hemostasis and thrombosis stewardship program, and gave great granular detail as to how that could be replicated. So there's a lot of effort in multiple hospitals, health systems around the country on implementing these programs. The playbook that I mentioned should be out later this year. The first draft we just got a couple weeks ago from NQF, and we're hoping to disseminate that and have that be another tool that people can use to really jumpstart their programs. And then we've got some other additional resources for engaging leadership at the hospitals that we're contemplating coming out with that focus specifically on business plans and things like that. So I've covered a lot of ground. I think I'm nearing the end here, Adam. Been a whirlwind. So what I guess I'd like to leave this as an open engagement, an invitation to collaborate with AC Forum. I think becoming a member and accessing the resources through the newsletter at no cost is an obvious no-brainer. I think making those recordings, those webinars, and the free CE available to your clinicians is also something that would be a very easy lift for any hospital or health system that wants to do that. If you are so inclined, and I would actually recommend it if you're thinking about getting a program up and running and you don't have the in-house expertise or facilities that you feel that you can really collaborate with closely, sending someone to our boot camp and our conference is a great opportunity to have them engage and learn and get on that path for collaborating with other organizations. The Center of Excellence status would be wonderful. Starting a stewardship program would be wonderful, and we're here to provide any resources we can for that. And then if you have any other ideas, Adam or any of your members, we'd love hearing them. And wrapping up, I don't like to leave just asking people for stuff, but I thought I'd come up with just one ask and one offer. And I think the ask, if I had if said, wow, was this worth doing today, would be, I would ask that just each hospital or health system that's participating in the call have a single high-level clinician, whether it's clinical pharmacist, a director of pharmacy, a physician leader, a leader in your nursing department, sign up as a member. There's no cost, and it gets you on that communication path of getting access to all those resources. And in return, although I don't have permission for this, Adam, I just thought if I put this in the slide while you were speaking earlier, is that I think and I was watching your data as you were giving your presentation, is I think I'll put my neck out and say AC Forum would do a presentation for this group on a specific narrow topic. If you, as you talk to your members and as you review the data and as you members of the Keystone program, if you identify an area, you say, oh, it's dialysis, it's obesity, it's VTE prophylaxis. If you wanted to narrow down a specific topic to get, or and maybe it's stewardship starting, I would make it happen to have that happen. So I'd like to put that offer out. So I'll stop there, and you're probably glad. I threw a lot at you, and I'd be happy to answer any questions you have, Adam, or anybody from the group.
Yeah, fantastic presentation, Darren. Thanks so much. Again, the call is out there. If anybody on the line or anybody at your organization would like to see that and would like a more in-depth presentation on anything you heard today from Darren, feel free to reach out to us, and we're certainly able to make that happen. So Darren, we had one comment. This is an incredible resource. Thanks for all you do. I echo that sentiment. This is just a treasure trove of free resources. Somebody else echoing the same thing. Great presentation. We did have another question. Let me scroll up here. So great presentation. Is there a national registry for anticoagulation? I know there is one for Blue Cross Blue Shield here in Michigan, MACI, M-A-Q-I. But is there something national you are aware of?
No, unfortunately, no. The MACI folks are wonderful. So that's the Michigan Anticoagulation Quality Initiative. If you're not familiar with it, Dr. Jeff Barnes, cardiologist from University of Michigan, is very active in MACI, and he's also on our board at AC Forum. So they're not national as far as the registry is concerned, and there is no national equivalent of them. But Jeff is everywhere, and I know he's working with people at the VA to advance some of the work that they've done with dashboards and things for managing those DOAC drugs. So there's no national registry. We do work very closely with Dr. Barnes and the others at MACI, and there's a lot of cross-pollination, but no, I wish there were a national registry. There are some different registries that I'm not intimately familiar with for specific disease states like atrial fibrillation and things like that. From a coag management standpoint, it's lacking. There's no official registration of the coag clinics. It's very hard. We've got our members who we know who are centers of excellence, but I think it's time. This is the issue. When you look at those numbers from CDC and how many people are on these things, how many harms, and to say we don't have systems in place, I think you've asked a great question, and I'd like to see us nationally move forward that way.
Great, excellent. And then I know we're right at time here, so I'll just read off the next. It's just a comment, not a question, but I think you're officially a hit, Darren. Great presentation. Thank you. This was very timely. We have a project going on right now around warfarin management among our primary care patient population. So that's great to hear. That these resources are, I think, going to be put to good use. So with that, we will certainly, follow up with you, Darren, after this call and see if we can arrange some further education as well. It seems like this is a great area of opportunity and value for the PSO membership, certainly.
Great. Well, it's a pleasure to collaborate with all of you. So anything we can do, please let me know.
Really excited to be here and have this opportunity of really going through this topic of health equity and thinking about the role of health equity in our patient safety journey. I do have to say, as a premise to this, is I would not characterize myself as a health equity expert, but I would characterize myself as a quality patient safety expert. And I think, like many of you, have been really thinking critically about the role of health equity as it relates to our areas of oversight. And I think the opportunity to provide this talk has actually been a wonderful step in my personal journey in thinking through some of the opportunities of really the role of health equity, how to make sure it's explicitly part of what we do in the quality patient safety space, and really, I think, is leading to an internal transformation for me as a leader in making sure that I'm not only thinking about quality and quality outcomes from an equity standpoint, but I'm also thinking through the patient safety implications as well. So the goal for today is really, I think, to go through and review some of the foundational definitions as it relates to health equity and patient safety. I want to review some examples of known disparities within the patient safety space and recognize disparities from my own experience. And then really, I think the whole point of today's discussion is to start a conversation in the patient safety world about what strategies should we be thinking through specifically about incorporating a lens of equity in our everyday patient safety processes. So my journey as a quality patient safety leader has really brought me into two organizations that couldn't be more different. So first and foremost, I'm a pediatrician. I'm a pediatric hospitalist. And I had the opportunity to train at Boston Children's and the Boston Medical Center, its combined residency training program. And really, through that shared experience, found a passion for working with underserved, diverse populations, and had the opportunity to be the inaugural pediatric director of quality and patient safety at BMC. And then my career ended up taking off about 10 years ago, and where I was asked to step up as an associate chief quality officer and then eventually becoming chief quality officer. And the Boston Medical Center is a unique place. It's the safety net hospital in the Boston area. We are like surrounded by Harvard and very much a Harvard system that is not geared toward taking care of the poor and the minorities and lower income patient populations, and really deferring that scope of work to Boston Medical Center, which we are very proud of. And really had both from a quality standpoint and thinking through the outcomes, as well as from a patient safety standpoint, really felt like health equity was something that was just what we did every single day. We didn't even have to make it explicit. It just was implied. When you have 30% of your patient population with a primary language that's not English, greater than 50% of patients who are identifying as African-American or Black, 20% being identified as Hispanic and Latinx, and then a lower socioeconomic footprint way below the federal poverty line. Anytime you improve a process, anytime you do a patient safety event, you kind of felt like you were in that role addressing a healthcare disparity. With my personal life and being from the Midwest originally, and then the pandemic happened, and I got this wonderful opportunity to move to West Michigan from Boston, Massachusetts. Wonderful is probably not the word that my 16-year-old daughter and my 13-year-old son are using, but wonderful for my wife and I, especially as we think about getting closer to family in the Chicago area. But really an opportunity for me to step up and move from being a single site institution chief quality officer to a system level chief quality officer. And in my personal journey, one of the things that was really important for me was to not lose my experience, my dedication to serving underserved populations as part of this move to West Michigan, that does not have the same level of diversity as what I was experiencing in the Boston area, and wanting to make sure that my passion for using quality improvement to address healthcare disparities was going to be part of my footprint here, and that has led me to specifically raising my hand or kicking down the door to be part of the system leadership aspects of the health equity work that's happening here. And then it also really has critically brought me to trying to think through the strategies that I want to incorporate as a leader of a system when it comes to improving quality outcomes and patient safety and ensuring that equity is part of our footprint. So that's just a little bit about me and this juxtaposition of these two worlds, and a bit of, I think, some validity around this opportunity for me to come to you as a patient safety expert, but a patient safety expert that has been steeped on an equity journey in addressing healthcare disparities for much of his career, now finding myself in a completely new position and trying to kind of recalibrate what type of leader I'm going to be as a quality safety champion in this moment in which equity has really kind of become front and center for all of us in our society. So my quality journey actually really centered on quality improvement. I have had the honor to be faculty at the Institute for Healthcare Improvement. I was academic advisor to the Institute for Healthcare Improvement on the for about 7 years, putting forth quality improvement educational materials as well as patient safety. But in that role, educationally was if you were to ask me 10 years ago, James, what do you have expertise in? It really was on the quality and quality improvement side of things. And that all changed when I was asked to step into the leadership role at Boston Medical Center. And I think really, I think it was a moment of like moral distress when as soon as you are incorporated into the bell curve of patient safety and really these protected private environments that really allow for very robust, transparent conversations about sentinel cases that go wrong, it really is this eye-opening moment. And I realized that as a leader, I needed to have an and statement with not only was I going to be good at quality improvement, but all of a sudden, very much, I was going to be a patient safety champion in the type of leader that I was going to be, and really, really push the patient safety agenda at the Safety Net Hospital in which I was at. I think part of that activation too was very much geared toward the fact that I'm a pediatrician. And one part of being a pediatrician is you're constantly risk adverse. Any safety event, any significant harm coming to a child, right, is beyond earth shattering. And so we live in a very risk adverse environment with a very risk adverse lens with how we practice medicine clinically. But then I think the other juxtaposition there was like coming to the adult world and really seeing the complexity and the severity of the patients that the adult colleagues have to take care of. But then also seeing how like patient safety was not indoctrinated as part of the mental model of care delivery on the adult side, in large part because I think morbidity and mortality is much more common, especially with elder patients. And so it becomes much more commonplace. And it just is one of the pivots in the lenses of my journey that really awakened me. And so I have 3 cases to share with you. And I'm going to use these cases as a vehicle throughout this presentation to really get to a conversation about equity and patient safety. But want to start off by just saying these cases were my eye-opening moment of saying, holy moly, we have an improvement opportunity. We need to put our arms around safety and really thinking through the systems of care at the Boston Medical Center to make things improve. So the first case that happened within my first 6 months of being Chief Quality Officer, we had an elderly patient who was admitted with for an elective hernia repair. And he was unfortunately found to have increased agitation and was repeatedly removing his leads overnight. And it got to being such a disruption for the local clinical team that they basically just outright disconnected him from a monitor. I think it was alarming like 300 times. And he unfortunately was found to have passed away the next morning. Another case that happened relatively quickly when I became Chief Quality Officer is there is a patient with neurocysticercosis, which is an infection, a central nervous system infection from a parasite. And this is a patient with a known infection who basically did have an external ventricular drain in place to prevent worsening increased cranial pressure, and ended up presenting with nausea and vomiting, visual changes, and an unsteady gait, which are all signs of increased ICP, to the emergency department. And the patient was sent for a head CT without being monitored and without any accompanying staff. And he unfortunately was found to be by transport to be in cardiac arrest after he got his CT image. And he was brought to the medical ICU where he was subsequently pronounced dead. The last case that was really jarring was related to a fall. A patient with a history of heart disease, alcohol, associated liver disease, prostate cancer was admitted for altered mental status. And the patient actually fell on the day of discharge and was sent down for a head CT that demonstrated a large subdural hemorrhage. And after being brought back to the room by transport, the patient was found to be unresponsive with bilateral fixed and dilated pupils. So really, I think there's no worse events than having these three, and they all happened within the first 6 months of me becoming a chief quality officer. And so the moral distress that you almost probably can still hear in my voice really, I think, brought me to a place of moral action and saying, you know, I need to figure out how I get after patient safety at the Boston Medical Center. So when I arrived at Spectrum Health, and just a name for the title here, so we are undergoing a merger with Beaumont Health, and so we've yet to formalize a name for the entire system. So for the moment, we are going with BHSH, but there'll be a new name for the system in the near future. But I'm still going to refer to Spectrum Health, and specifically Spectrum Health West Michigan, where I am the quality leader. So when I got to Spectrum Health and started to think about my role in equity, it really brought me into having discussions directly with the leadership who were responsible for the framework that had really been kicked off here at Spectrum for the last couple of years. And so this is the framework that we have at Spectrum currently, and it's very focused on the social and structural barriers. You can see that you know, when we think about the individual, how do we support the right activities to support and address their social needs? How do we think about our community partnerships and addressing social determinants of health over the long term in order to optimize health? And then what are the societal level structural determinants of health equity that we need to get after as part of the work? And my immediate reflection was, you know, where's the clinical space in all this? This felt and still feels to this day a bit external to the domain that I have oversight and that all of you have oversight of, is in the quality and safety space. And yet we know that you know, we have responsibility morally as we think about optimizing outcomes for all our patients, that we have opportunity within the quality and safety space to incorporate equity. And so I've been a very loud vocal advocate, purposely not trying to be disruptive, but really just feel like there's a need for us to think about the footprint of the clinical space and not ignoring the fact that we have implicit bias and sometimes explicit bias happening that actually negatively impacts the experience of our patients as well as their outcomes. And I feel very, very important as part of my role as Chief Quality Officer is saying, hey, I have the expertise, not necessarily in health equity, but definitely in the idea of how do we get after improving safety and quality. And I felt very, very strongly about incorporating a clinical footprint in the work as a supplement to the overall strategy we've had here at Spectrum Health. And so the way I've done that is a second and statement. So I brought you through those first three cases, which was my and statement of kind of saying, I'm not just the quality guy, I am the quality guy, and now I'm going to be the safety guy. And in a lot of ways, I think I'm adding another and statement, which is around making sure that equity is part of what we do. And so there's three priorities I've set with my leadership team as we think about the strategic priorities of quality in the quality space. And I think it's been very important to have equity explicitly identified as one of those areas. As to me, that means that we are going to have a portfolio of meaningful actions in which we are thinking about how to address inequities and outcomes that are actually within the clinical space, and really starting to get into the areas of opportunity that exist here. But I also know these are shared opportunities for us really across all of healthcare. So reviewing some foundational concepts, you know, I think it's a really important pivot when we think about the difference between what equality is and what equity is. And I think that this has been a really transformative mental model pivot for all of us, right? So this is the idea that just treating everybody equally, but ignoring their personal specific circumstances does not actually ensure that there's equity in health outcomes. And equity really is about making sure that we are providing the right resources in the right way for the right people to ensure that everybody has equity in the outcomes, especially within health and health equity specifically. And so I'd love, I'm sure many of you have already seen this used, and I think there's many different versions out there, but I love this one, right? Which is just like, in the first part of the visual here, you have equality where everybody gets one box, but not everybody's having an equal opportunity to really see the game. And so when you actually realign kind of your support services and your processes to optimize equity and outcomes, you are able to make sure that some patients are actually going to get more from a resource and support standpoint. But that's all in line with making sure that there's going to be equality and equity in the health outcomes of interest, and so that everybody can seize the baseball game. I think the other foundational definitions here that I think we're all trying to figure out how to better measure. So, real data and SOGI data, so race, ethnicity, and language, as well as sexual orientation and gender identity being all kind of components of the potential inequities that we needed to use as we think about different patient populations coming within our healthcare organizations and ensuring that we're really optimizing outcomes across all groups. And then last but not least is the knowledge that the conditions and the environments where people are born and live and learn and work and play and worship and age, that really 80% of the driver of health outcomes is related on the context in which people live and the environment in which they live. And in many ways, that narrative is why Spectrum Health is so strongly aligned with an external looking framework of supporting our communities and supporting the patient populations within those communities. And a bit of my stance is, hey, that 20% is really, really important. And let's not ignore the 20% of healthcare and the healthcare delivery processes and leverage my position to help influence that. So historically, when we think about the foundational concepts in patient safety, this is what we talk about, whether it's your journey to high reliability, making sure you have a just culture. I think all of us probably in the audience today would rate us very highly in kind of very understanding this, right? Like James Reason's organizational theory for safety and the Swiss cheese model. And then you have the idea of like human factors as well. And then within the patient safety spaces, like how do we actually mitigate liability risk, which is not the same thing as mitigating all patient safety concerns, but really going into areas that are leading to outcomes that actually lead to claims. And then, I think we've also been on a journey of recognizing that it's not just a traditional root cause analysis, but really being able to leverage a multimodal strategy in assessment and kind of forward action as it relates to safety events with the RCA squared take two, so to speak, framework that has gone forward. And so what I will say is like, this is what I know, this is what I dived in historically and really kind of formed the lens of like how we respond to safety events. And it's exactly what happened with those three cases that I went through where, okay, we did not take a blame-oriented approach. So that was good because I think those three cases really do like get your concerns raised. But for the first one, we took a very, very purposeful focus on delirium and making sure that people understood that like mental status changes and agitation in an elderly patient is actually a manifestation of delirium, and that actually is a patient safety emergency. And that we were then also able to think about how do we leverage our electronic medical record to assimilate delirium assessment into our standard vital signs framework and create an early warning system based on how people, what vital signs they're manifesting. And then we also really thought critically about like, well, if frail elderly patients coming in for elective surgeries need to be optimized both before surgery and after surgery, but also during their hospital stay, and really standardize a frailty order set as a result of the root cause analysis that we did with that case. I think the head CT, I think we all suffer from an inability to really proactively monitor patients in the holding area related to radiology. And especially in our resource constrained environment at a safety net hospital, we did not have available resources. And so we made the case to leadership about having a dedicated framework in which we're able to monitor patients more definitively within the radiology holding area moving forward, which was part of the gap there. And then, I think with the fall, very specifically thinking about not only the fall prevention and the fall prevention assessment really kind of fell into a framework where there wasn't really a major gap identified, but we did find real opportunity with, how do we identify at-risk patients who are from the floor and ensuring that nursing is available or someone is available that has a clinical background to go with those patients to radiology. I think for all ICU patients, that was just out of the gate what we do. But for floor patients, it's a little bit more of a mixed picture. And we actually created an initiative called Ticket to Ride that helps standardize, ensuring that when patients are in a clinical concerning state, they actually have someone who's going with them to keep them safe. So, stepping back and thinking about these two worlds of, okay, we have health equity and we have quality and patient safety. What we're starting to see in the literature and is really, policymakers and other influencers and how they are starting to think through the role of health equity in optimizing health outcomes. And I think a recent publication that, this one's from a cardiology journal, but there's one that's also from JAMA, actually from with Kedar from IHI's leadership, that's really starting to call for this idea that we are at another moment of an and statement. So, I think we all are aware of the triple aim as we think about like the importance of population health and alignment with value to ensure that we're optimizing outcomes at the time we are lowering costs, creating greater efficiencies, and ensuring that the right experience is happening. I think the quadruple aim really came out of the fact that the suicide rate of clinicians, it is a much higher rate than the population as a whole here in our society. And if anything, I think the pandemic has even accelerated the focus on burnout and depression and just how really kind of too commonplace that is. And especially, I think for us as patient safety leaders, I think the fact that we can't ignore burnout and depression and go on a high reliability journey that is blind to that would be a huge mistake. We really have to figure out how to better support our clinician workflows and ensuring that the mental health needs of that group is being more adequately addressed and ensuring that there's joy at work, not just suffering at work, I think is a huge piece. But I think, front and center is really now a fifth leg on the stool, if you will, which is health equity. And having this be an explicit aim of healthcare improvement is a huge call out to our space as quality patient safety leaders. And really, in my mind, is saying that like there's core responsibilities of healthcare organizations in our current state that didn't previously exist as explicitly. We all knew health equity was part of the 6 quality aims from crossing the quality chasm, but it didn't get the type of attention explicitly it needed to really move. And I think this is really a response to say, nope, we have to make this explicit. We have to make this purposeful, and we have to add this to the overall framework of how we think about healthcare improvement going forward. And so from my view, just because I'm sharing my screen, I'm not going to have a view of the chat, but I wanted to just really pose 2 questions to the group at this point, and feel free to put in the chat and comments. And when I get done with the presentation, we can take down my slides and happy to hear any comments. But I think one question I have for us as a group is really, does that move with the quintuple aim resonate with you? Does it feel right? Is that the right step to take? Is that the right frame shift as we think about how to make health equity front and center? For me, my worry is what happens when you have the 6th and the 7th and the 8th thing that's going to be added to the initial triple aim. And at some point you have to stop. And I think it's very, very important to me that health equity did get assimilated into the quintuple aim. But I just want to make sure that, eventually at some point, stakes in the ground have to be made and really basically saying there is a scope issue if it starts leading to scope creep. But for me, health equity fitting into that frame makes a lot of sense. I think the other kind of question and discussion is, I think many of our organizations probably have leaned into diversity, equity, and inclusion, and really thinking through kind of more implicit bias training as a mechanism of addressing perhaps some of the gaps in care that we see. But too often what I'm seeing with implicit bias training is it's an HR function, and it's not tied to our care of patients. It's actually tied to how we think about our hiring practices and our interactions with each other as staff and employees of an organization. But I think for us as systems experts, this is a leading question. is, why isn't implicit bias training enough to solve the problem? So feel free to put any reflections or comments in the chat.
So Dr.
Yes.
Sorry, this is Adam. We did have a couple, almost like a comment / question, but just to throw out to the group. So the first one is how to make implicit bias training not just a check off or checkbox type of training, how to make it more meaningful. And then another person chatted in that there's a triple aim for health equity in the public health world. So this quintuple aim resonates with me now that I am in the health sector or healthcare / hospital sector.
Yeah. Beth and Casey, thank you so much for putting something in the chat. So yeah, I totally agree. I think that is the real concern I have with implicit bias training as it's currently being undertaken. And I think we have an opportunity as clinical leaders over patient safety and quality to be the reason why it's not just a check the box type of training. And I'll get to that in part of my presentation. But I think we have some responsibility really to start thinking about implicit bias training for our clinical colleagues when we think about the influencing of the clinical space. And I think for all of us who have been on a patient safety journey, one of the common places that we start is by jarring patient safety cases, such as I've shown to you, that these 3 cases are actually the cases I presented to the leadership at Boston Medical Center to get the leadership to commit to patient safety as a need. And I think we have something very similar to do within the health equity space of making sure that our moments of implicit bias negatively impacting care or explicit bias and just outright racism impacting care have to be served up front and center to create anxiety for improvement. And at the same time, being really, in my part, as one of the anchors of the purposes of implicit bias has to be about how we think about taking care of our patients. And to me, that starts resonating in a way that allows it to not just be a check the box transaction, but that there's actually a reason to come through it because it's actually going to make you a better clinician and provider and make our teams better. And really appreciate the reflection from the public health space. I think the public health space has been living in the world of social determinants of health in a way that the healthcare organizations that are delivering care have not. And so in a lot of ways, I think we're kind of catching up to the public health space more definitively, and having more public health officials involved in quality patient safety specifically, I actually think is a wonderful win-win. And I appreciate the comments that are coming in around racism. And I agree, I think it's not just an individual problem. It's not just something that we need to think about individual remediation for. But again, I think a systems level look at racism and really getting after the structural and organizational issues and institutional racism is really an important component to addressing it. So really appreciate everybody, and please keep on putting reflections and comments in the chat. And Adam, thank you for pausing right there. And so I think, a really good lead-in is, we have a job to do. And I think in a lot of ways tied to those 3 cases, this is the jarring thing that I think we've all seen. And we've seen race, and we've seen examples of sexual identity and gender identity and sexual orientation, language barriers. Like, we know that these are factors that impact care. And I can tell you personally, I've yet to be in a position to really go after this in a way that I think morally is now something I'm much more activated. And so I think this is my call out to say, we do have a problem. We do have a problem in this space. And we do have something in patient safety that we need to get after from a moral standpoint and getting to specific actions. So let me go through, my recommendation, get this to work. My recommendations to all of us as a start. But again, one thing I'll just say is, like, this is really a start of a conversation. Like, I don't have the perfect recipe book that's going to basically get this done, but I love what I've come across, and I love what I'm going to end up proposing to you, because I know for me, like, these are immediately things that I can think about action on and really take steps here at Spectrum Health in my leadership role in doing. So first and foremost, I would just encourage us not to fall into the category of analysis paralysis. I think there's a lot of recognition that the capturing of race, ethnicity, language, sexual orientation, gender identity information within our electronic medical record systems are not ideal. But as a quality improvement person, what I'll say is if there's signal with bad data, there's going to be signal with good data. And so one of the things that we were able to do at Boston Medical Center was really get to immediate data analysis of like where we could point to disparities. And what we were able to identify within these domains was really kind of, again, with imperfect data, really tells a story. The fact that Black infant mortality was 4 times the rate of our white infants at the Boston Medical Center, that chronic conditions such as diabetes and hypertension would have a much higher prevalence within our patient population that was African American, and that unfortunately we were able to identify that our Black residents were 1.5 times more likely to suffer a premature death from cancer. Even something like influenza is 2.5 times or more prevalent in the Black communities, as well as you can see here, sexually transmitted diseases. And then from a behavioral health and mental health standpoint, the footprint of Black residents specifically were quite striking compared to the other patient populations we were taking care of, and then homelessness as well. And so, I think I'm in the mindset of about getting to action and improving data over time, and really just encourage all of us to think about what are the initial analyses we could just get after now, and really start thinking, how do we put front and center some of the stark disparities that we are seeing, even if our data is not perfect. I think number two was really trying to think through what are in the domains of influence from a quality patient safety leadership standpoint. And I think this is something that is a model that we identified at Boston Medical Center had relevance. And what I like about it is it clearly delineates what are constructs that are better addressed in partnership with the community and with a lens of that is much more external. Pre-existing disease burdens and the socioeconomic and cultural context. There's work that Boston Medical Center as well as Spectrum Health have to take on and will take on in those spaces, because we know that they drive 80% of the inequity in health outcomes. But what I liked about this model very specifically is it kind of said, okay, that's true, but as we are taking on those broad, long-range strategies to really uplift the patient populations we are serving and mitigate their disease burden, we have some action we can get to now, which is addressing bias in clinical decision-making, whether it's implicit bias or explicit bias. And then I think really taking a look at access to care, the patient experience that we're providing, and the engagement in care of our patients. And so for me, this has been my roadmap of what I, as a quality leader, feel like is within my line of sight to address as a supplement and in partnership with my health equity colleagues. So third, I think we all know that voluntary reporting is not perfect. It's not perfect in many different ways, but we're very much reliant upon it as we think about identifying safety gaps and making sure that we're have a very robust response to the safety events that are happening. But what's known about voluntary reporting, specifically as it relates to health equity, is that issues of implicit and explicit bias are very much underreported in voluntary reporting frames. And I think we have a real opportunity to think about automated triggers, and if not automated triggers, just standard clinical criteria triggers that would necessitate a chart review and an exploration for potential disparities in care. And so I think we do have some work to do to think about, well, what are those triggers? And we define those triggers, but I think that's a real opportunity for us to come together as patient safety experts and really move forward with the tool. Even if taking the IHI's global trigger tool that is around medication, potential medication events, that has been shown to identify disparities much more readily than a voluntary reporting system. So really, I think this is about an and statement, and for us to think very critically about the reporting environment. I do have to say that voluntary reporting is going to be, one of our central strategies forever as we think about the environment of safety for our hospitals. And I do think we even have an opportunity to think about how do we make within the voluntary reporting frame people very activated about reporting issues of explicit bias and implicit bias as part of the processes of what to submit that could be considered a potential safety event. I think one of the other journeys that is in the patient safety space is, how do we incorporate the role of emotional harm and emotional trauma into being considered a serious safety event? I think we have all recognized that there's been a historical bias in our safety world that it's physical harm that really dictates proactive safety review. But I do think there's an opportunity as it comes to equity and even issues of non-equity, that when there's a mechanism to measure and determine emotional harm, that that framework should really be incorporated into safety and really having the same level of weight within it in the sense of how we think about safety events. And so this was some steps that I took off in Boston Medical Center. And I think what we were able to recognize is that, I think the emotional harm space actually is incorporating potentially the roles of implicit bias and explicit bias that may be manifestations of care. And I think there's a real good opportunity to continue to push on definitions of emotional harm and what would be considered as triggers to more definitively treat it like a serious safety event. But I think we need to continue on really putting issues of disrespect and ensuring issues tied to undercutting someone's dignity needs to be incorporated into the lens of patient safety as a component of assimilating health equity into our world as well. And then, I think traditionally when we've thought about the word bubble slide that I had, whether it's human factors or high reliability journeys, I think that one of the, we have a pretty systematic way of making sure that the key factors that impact our patients when there is a safety event, such as staffing levels and case complexity and environmental factors, we have a list that we go through of those contributory factors, and none of them incorporate or include potential issues of inequity. And I personally feel like we have an opportunity to standardize our processes for any root cause analysis that's happening or any systems assessment tied to safety, and really make sure that we are explicitly asking, did the care team's implicit bias play a role? Was there implicit bias present? Was the care team's, what was the makeup of the race and ethnicity and the sexual orientation and gender identity of the patients in which the events happen? I think in order to do this, I would personally feel not qualified to be the person as part of a patient safety team that was thinking through these factors. And one of the recommendations that I came across that I think is really the right move to do is thinking about health equity experts as part of our patient safety teams. Health equity experts and incorporating them into helping us think through the strategies within serious safety event review frames, so that we can make sure that we are being purposeful in our action to incorporate an assessment of potential inequity and being treated with inequity as part of what we do in the serious safety frame, a reactive frame. So going back to those three cases, I did not include the racial identity of those patients or any of their issues with language barriers or socioeconomic status. But I think that they are relevant to these cases. It was an elderly white male that was admitted after elective hernia repair. And I think his elderly status specifically was a component that, that the fact that this patient was at higher risk for being frail and having delirium, and that wasn't necessarily incorporated into the lens of the clinical teams. The patient with neurocystic psychosis was a Hispanic patient who had low to moderate English proficiency as part of that safety event. And the patient who had the subdural after falling and ended up passing away was homeless and was African American. And I think it's really important that when we use these identifiers, that we think about the role of equity and inequity, implicit bias, explicit bias, as it relates to the serious safety events that do happen. And I think that the narrative and the lens of these cases does change, and it leads to a desire to know some follow-up questions. And I think that is the point of how we need to incorporate these strategies and equity specifically into how we think about safety more holistically. So this is just a summary of the 5 strategies, really making sure you get to data and analytics and not pause because of analysis paralysis. And then making sure that we are thinking through not only modifications to our voluntary reporting framework that could ask the question, did the case involve implicit bias or explicit bias, but basically formalizing our use of automated triggers and standard triggers for clinical review. Number 3 is, explicitly review bias in all safety events as part of the root cause analysis approach. Assess for and address and assimilate emotional harm into our safety frames. I think will add to our ability to recognize issues tied to inequity, and really, really strongly consider adding health equity experts to your safety teams. And so the final 2 discussion questions, I really, we can use the chat, and I'll drop down my slides and stop sharing just so that I can hear reflections and catch up to the chat. But what other strategies could be implemented to improve equity and patient safety? What's missing from my recommendations to all of you? And would love to hear also, have any of you really started to incorporate the lens of equity in your patient safety work and what you've started with? And then also finding out from the group, do you as an organization assimilate emotional harm into your qualifications for what merits a safety event review, either from your risk managers or from your patient safety teams? With that, I will conclude. So I will stop sharing. And Adam, happy to kind of turn it over to you if there's anything in the chat, but would love for any of you who are brave to unmute and share if any of your organizations are proactively assimilating health equity work in your patient safety work as a start.
Thank you so much, Dr. Moses. We did have no questions come in, or no additional questions, but a lot of agreement statements. Somebody also messaged that it's an excellent point to include the emotional harm and certainly using the health equity lens when looking at RCAs and doing event reviews and adding that as a contributing factor, certainly, into a lot of this.
Great, thank you, Adam.
Yeah, absolutely. So yes, please feel free to chat in your questions. I am very interested to hear if gets at one of your questions or one of your topics anyway, Dr. Moses, is how we could measure the emotional trauma or measure that aspect of harm, because I think it is a real concern, and there's a lot of agreements as well with that in the chat.
Yeah, and I'd be happy to share more broadly with you the scale that we were using. But we had the opportunity, and I had the opportunity back east in Boston, as well as the opportunity here at Spectrum Health, where the patient advocacy or the patient relations teams are part of my structure, my downline. And these are the teams that are called when there are specific patient concerns that the patients are raising related to how they are being treated. And one of the design principles I had with both of those teams was capturing in a database the issues that are being raised for kind of more formalized analysis. And the problem is that, obviously emotional harm is a very subjective measure, but we really we incorporated in Boston that after every single episode in which a patient relations activity was happening, that the patient relations advocate themselves would actually rate the emotional harm. And that if it met a threshold that we had defined in our scale as 4 or 5, which was, pretty the amount of either disrespect or just emotional trauma being to such a degree, we then explicitly incorporated a formalized review process of those specific events into the standardized process that we had with serious safety event review processes. And in the Boston Medical Center footprint, many of the events tied to those are disrespect events, and had incorporated, components to it of implicit bias and explicit bias. And so it is a way for us in that environment specifically to supplement our serious safety event review framework with the components of emotional harm. I do have to say it wasn't perfect, but it was better than doing nothing. And I'm more than happy, with this group to share that scale and have you guys improve upon it, because it's definitely a journey, for sure.
That would be great.
Looks like
Oh, go ahead, Clarence.
Oh, I was just gonna say, it looks like there's several questions and comments in the chat just now too, so.
Yeah. Yeah, I can help read through these. A lot of comments. Thank you all for chatting in. Love the concept of health equity by design, strategies, and projects designed with an intentional focus on equity as a core component. Another comment, I can't help but think how the current emotional trauma of the frontline staff impact our patient safety issues. Certainly. And then again, moving down the list, great comments and great action in the chat. Given a shortage of health equity experts in organizations, is there a checklist of considerations or questions that can be used during the safety event reviews?
Yeah, so there's nothing that I found in my research for the talk. If someone has been able to identify the resource, I definitely welcome you to share. But I do think there's a real opportunity for us to create within our own environments a list of those questions. But then I think more importantly would be to leverage the MHA to possibly share what people are using over time. This is definitely a journey, right? And we are so early on the journey. And I know I have personal work to do to really engage with my health equity experts here to think through some of those formalized questions, and seeing, really probably even thinking about it iteratively over time so that we can get to the signal that we're trying to get to with the questions that we are asking. And I think there's a real opportunity for all of us to take some of these steps really immediately. The other reflection I'll just share with you is it's pretty funny. On my journey as a quality improvement expert, the equity piece for me was, oh, I know what to do. I no longer will just have a certain performance threshold in quality improvement that I need to hit with every single one of project. We'll also assess for disparities. And I think there's been a lot of literature in that space, but there's been a lot less literature in the patient safety equivalence of this. And I think we have a real opportunity as a patient safety community to come together and really start, sharing what we think are evolving best practices. But I think that explicit and being purposeful about its assimilation into the patient safety space is really the first step along the many steps to come.
Wonderful, thank you. So moving down the list here in the chat, some other comments. Currently piloting an unconscious bias review in RCAs, have a laundry list of things I screen for, looking for unconscious bias of both those involved in the event and those involved in the review. Not measuring emotional harm or scoring the harm, just collecting data at the moment. And then it looks like some great resources are shared as well.
Great. Perfect.
Great. So another comment, emotional harm is considered, but really in the context of when physical harm occurs. It is not addressed independently yet. I think that's a wonderful comment. Great observation.
Yeah, I think that commonly happens. I think the nice thing about the patient relations arm of measuring this is because it's not necessarily a safety event that is the trigger for the reach out of a patient relations frame. It doesn't necessarily need to be the emotional harm as it relates to a physical harm event, but really leveraging patient relations teams or patient advocacy teams, wherever they are, and really saying that they their early signal to areas of emotional harm that I think need to be incorporated into the safety framework definitively. So this is great. Well, I really appreciate everybody taking the time to put those resources within the chat. And I'm really looking forward to kind of continued discussions and conversations in this space. I think there's some things that I will share with Adam that he can then send out as a supplement to this presentation, but really welcome all of you that we come together as a community, as a learning community. And if any of you have evolving best practice, would really welcome you to share with Adam as well based on this. So I really appreciate everybody taking the time to be here today to listen to the talk. And Adam and Clarence, thank you so much for inviting me.
Absolutely. And thank you so much, Dr. Moses. Again, fantastic presentation, incredibly timely and relevant. And I think the engagement in the chat is a testament to that. And certainly if anybody, as Dr. Moses said, if anybody has ideas or other comments you want to share, please do feel free to reach out to us. And if you do chat in any questions and we don't get to them because of time constraints, we will follow up with the speakers on those questions and get kind of an FAQ or Q&A, excuse me, page going that we can then post along with the slides. So thank you very much once again, Dr. Moses. Welcome back, everybody. Hopefully you had an enjoyable lunch and a good break, able maybe to recharge and catch up on some email or phone calls. And I'm very excited to, that we're going to have our next guest presenter, Brian Sexton. My colleague Clarence is actually going to do the introduction, but as you well know, and it was up on our break slide over lunch and for the morning break, we're offering in partnership with Dr. Sexton a healthcare staff well-being improvement program. So I'll let him fill you in on all the specifics and all the data supporting everything, but I'll hand it over to Clarence right now to do a formal introduction.
All right, thanks, Adam. Our next speaker, Dr. Brian Sexton, is going to talk to us about bite-sized well-being during times of uncertainty. Dr. Brian Sexton is the director of the Duke Center for Healthcare Safety and Quality. He leads the efforts around research and training that guide our quality improvement and well-being activities. A psychologist member of the Department of Psychiatry, Brian is a psychometrician and spends time developing methods of assessing and improving safety culture, teamwork, leadership, and especially workforce well-being. Everyone, please join me in welcoming Dr. Brian Sexton. Brian.
Thank you so much, Clarence, and thank you all for having me today. I've been really looking forward to sharing some of this with you. What we're going to do is I'd like to share with you some data that we have about the state of well-being across the country right now for healthcare workers. I want to show you a specific thing that's very popular that people can do about their well-being right now if you're a healthcare worker, or maybe you know a healthcare worker. And then I want to share with you some resources that recently became available to Duke and to the Michigan Hospital Association that allows us to bring more resources into your work settings across the state. So to kind of introduce you to this concept of well-being, I want to make sure you understand the resources, the links that we're going to be providing. If you like them, you can share them with others. So check it out, see if it's something you want to do. And if you like it, please feel free. Anyone who is a healthcare worker, clinical or non-clinical in Michigan, can use this. I'm going to give two links today. One's going to be to a specific tool that is popular for well-being in healthcare workers right now. And then the other is going to be a link to resources where you can get continuing education credit. You can get links to all the articles and the science and the evidence that we'll be talking about for things that you can do for well-being. And also you can get a copy of the slides. But before we get into all those resources, let's just imagine that we were not on a Zoom today. Let's imagine that we were in some nice kind of hotel ballroom and there's a big screen in the front and we're all kind of gathering around coffee urns and debating whether or not we think the food really is good in this hotel. But in this particular imaginary scenario, please imagine that there's all these table rounds in the room half of the table rounds have one sign and half of the table rounds have another sign. Now, every table has a bowl of freshly baked chocolate chip cookies, and every table has a bowl of radishes on it. But half of the tables have a sign that says you can eat the cookies, but not the radishes. And the other half says that you can eat the radishes, but not the cookies. Now, you were told where to sit, so you don't really have a choice. You kind of ended up where you ended up. And what we're talking about here is you watching the continuing education content all day long. MHA puts on a good show, all day long you're watching it, and half of you are sitting there staring at a bowl of delicious, freshly baked chocolate chip cookies, and the other half of you are just looking at those radishes thinking, I wish I had sat at that different table. What happens in a study like this, and this is a paradigm that they've used repeatedly in the social science, is it's a test, it's a challenge to your available willpower. The cookie eaters, the ones that were allowed to eat the cookies, they were able to pick them up and taste them if they wanted. The radish eaters, they could pick up and touch the cookies, but they weren't allowed to eat them. And so as you're kind of having that tempting thing there in front of you all day long, it's a challenge to your willpower, which starts off like a full battery and it gets weaker as the day wears on. It starts off like a full battery, but if you're challenged all day long, it becomes weaker. So the next step in this kind of paradigm in the research is that they do something really nefarious. Both groups, the people sitting at the cookie eater tables and the radish eater tables, they were all given a puzzle to perform. And this puzzle was a puzzle of persistence because it had no true end. And so like the test that was earlier given to the radish eaters, it was a test of available willpower. You might find it interesting that the cookie eaters averaged 19 minutes on an unsolvable puzzle. They persevered for 19 minutes. The radish eaters, they persevered for 8 minutes. I want you to think about well-being in this way. How do you feel after a long, busy day, after meetings and working on projects and dealing with, denial of certain viruses that are out there and what to do about those viruses and rushing around? Do you still feel like you have the energy available to you to work on your goals after a long day? Do you prioritize your well-being? Most of us want to just veg out in front of YouTube or TV and avoid doing anything at all. And the reason that you might find yourself so exhausted and burned out after a hard day can be influenced by what psychologists here refer to as the ego depletion effect. So ego depletion is this idea that self-control or willpower draws upon a limited source of a pool of mental resources that can be used up. And when that energy for mental activity is low, self-control is typically impaired. And that's what we call ego depletion. So we're using our self-control. We're using our willpower during COVID and during political unrest and during land wars in Europe. And when we're interacting with family members of patients that don't understand why they have to wear masks. So disruptive patients, disruptive colleagues, all of these things, they use up our reserves faster than we realize. There's a compromise here. Just eat the cookie or please just put the cookies away so you don't have to see them and they're not tempting and draining your available willpower. But the reason I give you this example is, number one, there's a lot of data behind this and this effect of the draining of available willpower, but also we want you to kind of think about well-being in a slightly different way. A lot of times people think of well-being as happiness. How happy are you? But really, we think of well-being as the ability to do stuff, because as your well-being is compromised, your ability to do stuff is compromised. Let's talk about what this effect this has had on healthcare workers, because what's happened during the pandemic? Well, roughly a third of healthcare workers reported, a third to half of healthcare workers reported burnout before the pandemic. Now, at this point, that number is closer to 2 out of 3. So people who work in healthcare right now, technically, have a chance that is worse than a coin toss of being burned out simply by virtue of being a healthcare worker. This is the equivalent of going live with 2.5 to 3 EMRs back to back in 1 year without any break in between. You would never do that. That's why this feels so very different. So our burnout is up. Our reserves, our willpower is those are depleted, and we're being asked to do continuously difficult things without a whole lot of break in between. Now, Tate Shanafelt, who's the world's leading researcher on physician burnout, just recently published a new data set showing here that well-being for physicians from 2011 to 2014 to 2017 to 2020 has changed significantly. From 2011 to 2014, I'm just going to speak to the mean here. This is just physicians. I'm going to show you more data from other groups there in a second. But for just physicians from 2011 to 2014, there was a huge increase in burnout amongst physicians. You might remember what we did at that time is the whole country went live with EMRs, and that was quite a drain. Then we kind of adjusted that. Some people retired, some people figured it out. And that's what we saw by 2017, the burnout level had changed back to about 45%, about almost half of healthcare workers. It went from almost half of healthcare workers being burned out that are physicians to more than half to almost half again. And then something interesting happened in 2020. The burnout level went down again. It went down significantly. So burnout amongst physicians kind of teeter-tottered around, but from 2014, when burnout amongst physicians was 54% of all practicing physicians, now that rate is 38% in 2020. Well, we have even more recent data from our lab, and you are some of the first groups to ever see these results. They are, we've actually been in discussions. We've already shared this with the editors at JAMA. So please, if you have comments or thoughts about this, let us know. Here is our results. We have data actually from 30,000 healthcare workers. And we collected this data in September of 2019, September 2020, and then in September of 2021. One of the groups, we collected it in December of 2021, and that bled into January of 2022. So I want to tell you these three waves of survey data that we have on healthcare worker well-being. One is before the pandemic, one's during the pandemic, but before vaccines. And then the third wave, this third one here, this is after vaccines, after Delta, and at the beginning of Omicron. I just want to kind of clarify, these are these three waves. What does it look like for 30,000 people? Well, let's take a look. Overall, there was a significant increase in emotional exhaustion reported by healthcare workers from 2019 to 2020. Another significant increase from 2020 to 2021. That's overall for 30,000 people. But there's a very different pattern of results when you look at nurses versus you look at physicians. Our nurses increased the most from 2019 to 2020. This was a very stressful time. We didn't have what we needed to do. We didn't know, we didn't have the equipment we needed. We didn't have the predictability that we needed. From 2019 to 2020, there was a lot of difficulty at the bedside for our nurses across the country. From 2020 to 2021 for nurses, they continued to get worse on their emotional exhaustion. But the real big increase was from 2019 to 2020. It's almost the opposite pattern for our physician colleagues. Physician burnout went down significantly from 2019 to 2020. Volumes were down. There was more flexibility. Telehealth really took off. My best friend is a interventional radiologist at Duke, and he was able to sit in at home and 3 days a week and have lunch with his wife and his two kids. It's a different world for those who, now these aren't like physicians that are just working in COVID units. This is all physicians across the country overall saw a decrease in their emotional exhaustion. But from 2020 to 2021, they showed a very dramatic increase in their emotional exhaustion. That is a really large increase in 1 year for a very large group of people. It was much worse in 2020 for our nurses than our physicians, and it was worse in 2021 for our physicians than our nurses, relatively speaking. So why am I telling you all this about what's happening? I want to just set the stage so you can understand COVID has impacted different healthcare workers in different ways. And what I can tell you, most healthcare workers that are in the other category here, this is techs and pharmacists and therapists and social workers and administrators and managers, they all follow the same pattern as the nurses. It was the physicians that had that kind of distinct difference. But the question that we get from all sides right now in 2022 is this: how on earth am I supposed to improve my well-being during a global health crisis? And this is exactly why we need bite-sized, simple strategies that are evidence-based and that work. This is not the time to suggest meditation or yoga or to go train for a marathon. Those require initiation energy that people just don't have right now. So you may ask, legitimately, whether bite-sized strategies are even effective. And we would say, hey, take a look at the randomized controlled trials, the gold standard. We know now that using these bite-sized strategies that I'm going to share with you now, that we're sharing with the state of Michigan, together Duke and the Michigan Hospital Association, these strategies, we've already published them as randomized controlled trials of healthcare workers. And we've shown that we can cause emotional exhaustion to decrease. We can cause problems with work-life balance to decrease and stay decreased. So these are significant reductions in burnout. These are enduring improvements in well-being. And this is very important because we know that healthcare worker burnout is associated with patient engagement and infection rates and medication error rates and things like standardized mortality ratios. We collect these data at Duke ourselves. And what we have seen is that our burnout predicts turnover. It also predicts preventable harm. So the burnout rates amongst our work settings at Duke actually predict where we're going to have preventable harm as collected through our incident reporting system, our RL Solutions, which is what we use. And it's important too, because when we look at some data that we tend to pay a lot of attention to, we collected, in addition to this well-being data, we collected our Press-Ganey data. And isn't it interesting that when you look at Press-Ganey data, it does not predict turnover, and it does not, in our sample, it does not predict preventable harm, but it does predict, but you know what does predict turnover and preventable harm are things like work-life balance and emotional exhaustion and how burned out you say your colleagues are. So those well-being indices are really important, and that's what we're targeting. How do we really impact those well-being indices? And to answer that question, I want to give you a little glimpse into how we look at well-being. So let's take a look at the psychology of burnout. What do we mean by burnout? And what we say here is that your focus and your reflections are what determine your reality. And another way to say that is what you're looking at is what really kind of determines what it is that you are focusing on. Your focus determines your reality. To give you a clinical example, if you are a radiologist, if I were to show this scan of the CT scan of lungs to a room full of radiologists and say, do you notice anything unusual in the scan? Isn't it interesting that 4 out of 5 of those radiologists would not see the gorilla in the upper right-hand quadrant? Let me go back. Maybe you see it now. Why is that? Because radiologists are trained to look for, in a cancer screen like this, they're trained to look for the white or light colored nodules. And the gorilla, of course, is dark. It being dark, the eyes skip over the gorilla. So why do I present this to you right before we talk about burnout? The same thing happens in burnout. When you are burned out, you are drawn to the negative, you are drawn to the bad. You don't see the good that's right in front of you because you've trained your brain to think about the bad. In an interesting example here from Renzo Bianchi's work in Germany, Switzerland, and Austria, they actually put helmets on people's heads. There's a visor in the helmet where you can have a screen, and there's gaze tracking where you can see what participants are looking at on the screen, and they'll flash positive images and neutral images and negative images on the screen. Isn't it interesting, though, that burned out participants, just like depressed participants, they will skip over the positive images, they will skip over the neutral images, but they focus like a laser beam on the negative. In fact, when you take the helmet off their head afterwards and you ask them to recall what images and scenes were played on the screen in front of them, they can tell you with stunning accuracy and detail what was in the negative images. They remember the negative, but they cannot recall the positive or the neutral. Isn't that interesting? What is the biological reason for that? What is the evolutionary reason for that? Well, historically speaking, if you are running from a threat, if you are trying to avoid a threat, something that is going to get in your way of passing your genes on to others, the way the mind it works now is that you're going to focus on things in front of you that might also try to eat you or get in your way. If you are actively avoiding a threat, if you're running for your life, you're going to look for other things that could get in your way or eat you. Now, that means you're going to be tuned in to the negative as a survival strategy. That's a great way to keep your genes in the gene pool. Because if you stop to kind of appreciate a lovely sunset or a rainbow, you're not going to be passing your genetic material onto your children. That's kind of how that works. The problem, though, is that we use the same strategy for things like problems at work and problems at home and the prime lending rate. And whenever we look at social media, we turn on the news, we're just constantly drawn to the negative. This is our negativity bias, and it prevents us from noticing good things that are happening right there in front of us. And all of you as leaders listening to this content today, in these virtual sessions, you know that you've seen some things get worse and some things get better, but here lately, every time there's some good news, it's like, yes, you present it to folks and it just bounces off of them like opposing magnets. You can't get it to stick. Well, part of the reason for that is that we're all in this zone where we're looking for information that confirms how bad everything is. We're not looking for and open to information that challenges that or tells us that things are going to be okay. And that's a survival strategy. We need to have some self-compassion for ourselves, and we need to have some serious compassion for others as they're trying to struggle with that. The reason this is important, and we bring this out, is because another big part of well-being that we've learned over the past kind of 5 years with our research is that it's not just the ability to see the good, it's the ability to see the good and the bad simultaneously across situations. Those individuals that are the most resilient, those individuals who are really ready to bounce back after adversity are the ones that see the good and the bad. They're not Pollyanna-ish about how wonderful everything is, and they're not overly negative. They can see, well, yesterday was bad, but today's better, kind of a thing. So if that's what we mean by well-being, well, what do we mean by burnout? And to do that, I want to introduce you to this. I want to share with you the grand poobah of burnout research, Christina Maslach. She's a magnificent person and a wonderful scientist, and I can't say enough positive about her as an individual. If I can channel Christina for a moment, she would say there are 3 pillars of burnout. Any one of them is enough to be burned. You have to have all 3. Any one is enough to be burned out. The first is emotional exhaustion. This is where you feel like you can't meet the demands that are placed upon you. This is the most common form of burnout measured in healthcare and outside of healthcare. It's also the most predictive of outcomes in healthcare. So if you're looking at for a single measure of burnout in healthcare, this is a really good one. The other 2 are called depersonalization, where you kind of see others as objects. This is also referred to as compassion fatigue by some. And then the third is called inefficacy. You just don't feel like you're good at what you do anymore. And any one of these is enough to be burned out. Many of us have all 3 of these going on simultaneously, but the one that really predicts outcomes, clinical and operational outcomes really well, is emotional exhaustion. So the items for emotional exhaustion look like just like this. I'm burned out from my work, frustrated by my job, I'm working too hard at my job. Things that happen here affect my life in an emotionally unhealthy way. Though if you're agreeing with these items, that's burnout. If you're neutral, even if you're neutral on these items, that's considered mild burnout, and it still predicts turnover and harm and patient engagement. It's those people who are disagreeing either slightly or strongly with these items that have the better outcomes. So let me just say that all this kind of these pillars of burnout, this is kind of fancy schmancy language. It's a little bit complicated. And I learned that we were going about this the wrong way from my daughter, Tatum. This is my youngest. I have 4 children. I'm the ridiculously proud father of 4. And Tatum asked me not too long ago, she says to me, "Daddy, you are always talking about burnout. Burnout, 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 burnout. What is burnout, Dad?" And I had one of those kind of moments where I was like, "Whoa, oh, honey, burnout is comprised of 3 pillars. There's emotional exhaustion and depersonalization and a diminished sense of personal accomplishment. You aren't following Daddy, are you, honey?" And she says, "Nope." So I said, "Well, honey, all right. If I can't explain to my then 7-year-old, what it is that I do for a living, how on earth am I going to be able to help others in my day job?" "Okay, well, honey, look, burnout is basically what happens when it gets really hard to notice that something is funny or something is interesting or something is amazing." And Tatum says to me, "Oh my gosh, Daddy, that is so boring. I used to tell all my friends you worked at Duke, and I'm not telling anybody that anymore." True story. But the next day we took this like new definition to work. We worked out, we fiddled with it a little bit. We published it several times since then. It actually, I learned from my daughter a new way of conceptualizing our research questions. And so now we say burnout is essentially this impaired ability to experience positive emotion. And in this new definition of burnout, which we've operationalized and used in our randomized controlled trials, we can now test is burnout, when it increases, associated with more positive emotions? When it decreases, is it associated with less positive emotion? Yes. If you use interventions that create more positive emotion, do you see burnout go down? Yes, you do. When you have situations that reduce your access to positive emotions, do you see burnout go up? Yes, you do. There are 10 of these positive emotions, and they come to us courtesy of Barbara Fredrickson, who's a psychologist at UNC Chapel Hill. She's the 6th most cited psychologist in the world. And a really amazing researcher also. And she says there's joy and gratitude and serenity, kind of being at peace with the world. There's interest, curiosity, hope. Hope is a powerful one. And hint, I'm going to come back to this one in a second. There's pride and amusement. There's inspiration, awe, and love. All of these together, all 10 of these positive emotions together have a very powerful impact on your well-being. Let me tell you 2 ways that they have impact on your well-being. Number 1, Barb Fredrickson and her work over the past 30 years has shown that there's an undoing effect of positive emotions. If you are experiencing an emotional upheaval, and you also are able to experience a positive emotion, it undoes the physiological consequences of that emotional upheaval. What do I mean by that? Well, there's this lovely study where, and she's done this about 12 different studies now, where they upset people. How do they upset people? This is why people don't like psychologists, because we show them radishes instead of cookies, and we do stuff like what I'm about to explain to you. She brings people into the lab. She tells them, I'm so sorry to do this, but I'm going to hook you up to a bunch of electrodes. We're going to look at your galvanic skin response, your respiratory rate, your heart rate, your vagal tone, and we're going to take some baseline measures here. And then once they're all hooked up and we have all their baseline physiological measures, she then says the next thing we're going to do, I'm sorry to say, is that we are going to have you walk into a room over there, and we're going to give you 1 minute to prepare a 5-minute speech that you're going to give in front of 50 of your peers. So you can imagine the fear of public speaking is pretty common. Everyone very reliably gets upset. You can look at the extent to which they're physiologically upset using a whole bunch of different parameters. Vagal tone in particular is a really big one. And what they've found is that if you do that, but then instead of actually having them give that speech, you simply have them watch a video that is either funny or full of serenity and peace, or a control video or a negative emotion video like sadness. What you're looking at on the screen is the time in seconds that it takes to recover to your baseline level of cardiovascular reactivity. This is using positive emotions to undo the consequences of an emotional upheaval. And this has been replicated many times. To feel like something is funny, to feel at peace, it calms you. It slows down your kind of way of looking at the world. It makes you feel safer. That's one of the ways that we actually begin to recover. Now, that's one way. It's through positive emotions that we are able to bounce back, and it's through positive emotions that we achieve meaning and purpose. So I double dog dare you to try to feel meaning and purpose. I dare you to feel like you're making a meaningful difference at work without experiencing one or more of those positive emotions, like pride or hope or inspiration. You can't do it. It's just the way that we're wired. So it's through positive emotions that we experience meaning and purpose. And it's through positive emotions that we recharge our batteries when they get depleted. So let me give you the definition one more time. Burnout is the impaired ability to experience positive emotion. So if now you understand this, you can say, if I want to do something for well-being with my staff, if I want to do something for well-being for myself, if I want to work on burnout, I hope there's some component to it that is going to create more access to positive emotion or easier access to positive emotion, because it plays a very critical role in our well-being. So the question that we get most commonly right now is, with the world on fire like this, how on earth am I supposed to access hope? Well, guess what? Hope is a positive emotion, and it fits into our rubric of what we were talking about before. Hope is, in my mind, it's probably, I'll just speak for myself. I think that hope, so far from the data that I've seen, from the research that we've done, it is the most important positive emotion. They're all important, but this one really punches above its weight in terms of the impact it has on well-being. Now, Barbara Fredrickson would very consistently say love. So I want to kind of acknowledge that. She says that love is the most important. But in terms of the interventions that we use, in terms of what we can manipulate and create reliable, replicable effects for, hope is really powerful. So let's talk about hope for a second. And I want to share with you an intervention that you can use for yourself and others. Hope is not your typical form of a positive emotion. Most positive emotions, they arise when we feel safe and satiated, but hope is the exception. It comes into play when our circumstances are dire. Does that sound familiar right now? Things are not going well, and at least there's a considerable uncertainty about how things are going to turn out. Hope arises precisely in those moments when fear or hopelessness or despair would be just as likely. Perhaps you've just lost your job, or dreams of starting a new business or retiring, or hope in times like those is what is called fearing the worst, but yearning for better. It opens us up, it removes blinders of fear and despair, and allows us to see the big picture. We become creative. It's a very, very powerful positive emotion. And I want to take a detour, now that I've kind of introduced you to the concept of hope, to say I'm not a big fan of the Friedrich Nietzsche quote that says, "That which doesn't kill us makes us stronger." I don't agree with that. The pandemic has taken things from us. It has revealed things to us. Sometimes we learn things about ourselves and our fellow humans, and that information is not what we wanted to know. Maybe we weren't ready to have all these revelations about what's going on in the world and what's going on in society and what's going on with that other political party that I'm not a member of, whatever that may be. I don't like this quote. I don't agree with this quote. I don't think that this is true. In fact, If it didn't kill you, thank heavens it didn't kill you. I doubt it made you stronger. Maybe if you're paying attention, you can be wiser the next time something like this might happen, but I doubt it made you stronger. Instead, I like the Leonard Cohen quote. The Leonard Cohen quote is, "There's a crack in everything, and that's how the light gets in." See, the pandemic has revealed so much to us, and if we were open to that, what it is that has been revealed, we can really grow much more wise than we were before and increase our well-being at the same time. There's a crack in everything. 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 And that is how the light gets in. So why talk about the crack in everything? Well, because the opposite of depression is not happiness. In fact, the opposite of depression is that middle positive emotion right there. It is hope. The opposite of depression is hope. Hope is the ability to look forward to things and assume that they're going to be better. Hope is the ability to say tomorrow can be better than today. When you become emotionally exhausted, when you become burned out, it's very similar to what happens when you become anxious or you become depressed. You look at the future and say, tomorrow is not going to be better than today. Well, we have learned over time that there are several well-being hacks that you can use to help you to bounce back, to help you to recover some of what the pandemic has taken from us. All of these different positive emotions and activities have a component of resetting or recalibrating or changing your perspective on the current situation. And of all of these, the one that really works well is hope. The opposite of depression is hope. And what's really neat is that let's take a look at some data. I want to share with you some of the evidence about this. We know that optimism is the psychological attribute that we characterize as hope in the literature. It's the general expectation that good things are going to happen. Optimism is the belief that the future is going to be favorable because we can control important outcomes. And measured in this way, optimism predicts less chronic pain, better immune system functioning, lower blood pressure, and lower all-cause mortality. How much so? How much evidence is there? Well, let's take a look at some of the evidence. Here's a nice JAMA article where they followed 1,000 elderly Dutch citizens for 9 years. And during these 9 years, there were 397 deaths. They found that the level of optimism predicted all-cause and cardiovascular mortality for this large sample. If you don't like the JAMA article, here's one from the Proceedings of the National Academies of Science, where they showed that the optimism is specifically related to an 11 to 15% longer lifespan on average, and to a greater odds of achieving what's called exceptional longevity. That is, living to the age of 85 and beyond. And so people who live to be the age of 85 and beyond have, on average, much higher levels of optimism. And so this was independent. This is what's really important. This was independent of socioeconomic status, health conditions, depression, social integration, and health behaviors like smoking or diet or alcohol use. Optimism is an independent, important predictor. Let's look at some more evidence. Here's one from the Journal of Circulation. It was a study of 97,000 people. They showed that optimists had a lower hazard of coronary heart disease related mortality, and overall mortality. This was a clear big sample, and in this case, it was focused on women. We need more data for well-being when we look at demographic groups much more cleanly. Also, a recent article that we published about hope shows that hope and optimism can be improved over time with repeat exposures to these bite-sized interventions. And that's what I want to talk to you about today. Marty Seligman actually showed us, he was the president of the American Psychological Association for about 8 years. He's a clinical psychologist at the University of Pennsylvania. He actually showed in his research that hope is a muscle that can be improved. He also showed in his research that helplessness or despair or depression is something that you can cause in rats and in dogs and in humans. But he got so tired of that research that he kind of flipped it and started studying, instead of on despair, he started studying on well-being. Started doing these studies on in particular optimism. And what's the good news here is that it's a muscle that we can strengthen with practice, with very simple bite-sized strategies. What do I mean by that? Well, I'd like to share with you the resource that we put together for this, but it requires a mobile phone. All you need to do this is a mobile phone. If you have a mobile phone and you can put it in camera mode, I'll give you a QR code on your screen and show you where you can get access to one of our most popular the most popular well-being tool right now during this phase of the pandemic, and it is our Looking Forward tool, our tool for cultivating hope. The bit.ly link is bit.ly/FWD tool, or you can just hold your phone over the QR code there on the right-hand side of the screen, and it'll take you straight to the tool. This is not an app. We simply use your phone to send you some text messages for a week, and then it's done. It's not an app. You don't have to download anything to your phone. I'll leave that QR code up there so you can see it. The reason that we do this is because by sharing these little tasks, 1 to 2 minute a day tasks for a total of 8 days, here's what it looks like. We actually can help you to flex your muscle to make hope stronger in your well-being portfolio. It can be a stronger part of that. This is exciting because we already see the effect by day 4, by day 7 of our follow-up, because we do this across a week. By day 7, we see a significant increase in your ability to look forward to things. We see a significant decrease in your depression, a significant increase in your optimism, significant improvements in your ability to thrive and recover from adversity. The whole time it takes to enroll in this thing is 2 to 5 minutes. It takes 1 to 2 minutes each evening, and it takes 8 days to do the whole thing. Today and 7 more days, and you're done. 4 out of 5 people said that they enjoyed it. 94% said it was straightforward. 3 out of 4 people said it got easier to use over time, even though we made it harder to use the tool over time, because what we're doing is we're shrinking down the window that we use for you to envision things that are happening in the future. And as you get closer and closer to the current moment, that's for people who are burned out, for people who are anxious or depressed. That is the harder task. It's easier to think about things in the far future. It's harder to think about, well, how hopeful are you about tomorrow? Well, not very hopeful. Well, how hopeful are you about 15 years from now? Well, there's a lot that can happen in the next 15 years. And we have taken advantage of that effect, and we have put it into this bite-sized tool. Now, what does it look like? Depression, optimism, recovery, thriving, all of these are statistically significant effects, but it is the depression effect that really dwarfs all of the other effects that we report here. Now, every time we give you a tool, we also give you a flyer. So there's the forward tool flyer, there's a QR code that you saw before, and the little bit.ly link, and these flyers you can put up. But if you want to sample, this is what I've done for you just now, is provided a window into what it looks like when you participate in the well-being series through the Michigan Hospital Association and through Duke University. What we are trying to do is give you a glimpse of what the tools look like, of what the presentations look like. And you can grab an hour of continuing education today. I'll show you how to do that. You can use the tool and share this tool that I shared with you just now today. But every single one of the 10 sessions that we are offering for free to everyone across the state of Michigan, clinical and non-clinical, every single one of them comes with a summary. In the summary, we cover the things that we talked about. Like today, we said that hope is a muscle. We talked about the importance of positive emotions, and that burnout is the impaired ability to experience positive emotions. We talked about the prevalence of burnout. So we covered that. We share with you what those different aspects of the presentation are in a summary. We then tell you, here are things that you can do. Well, if you haven't done it yet, you can finish the forward tool. You can normalize burnout, because it's so common, by validating it for others, by saying, what is it that you're looking forward to in an elevator conversation, by asking people at the dinner table, tell me what you're looking forward to, next summer or next year. You can read and share the articles that I'm going to share with you. If you ask for the continuing education credit from this hour that we're spending together right now, you can share the forward tool flyer that I'll send to you if you ask for the hour of continuing education credit. And you can also ask others what it is that they're looking forward to. That's the simplest thing, and it makes a pretty big difference in well-being. So let me show you where you can go to get your hour of continuing education credit, but then I want to kind of demonstrate the full program. So if you're interested in getting a continuing education credit for now, it's a CME and CEU credit. You can scan the QR code or just enter in the bit.ly link. Just type that into your browser. And if you do that, now I'll leave over here on the right-hand side, I'll leave the link and the QR code on the screen for you. Well, if you do that, we'll send you an email. And we do this after every single one of our sessions. We'll send you an email. The email has your continuing education certificate in it. It also has a copy of the slides that we just covered. It has the link to the tool, a link to the tool flyer, and then all the articles that we talked about during the presentation, so that you have all the science in one place. For some people, they care a lot about seeing the evidence. For other people, they care less so about seeing the evidence. We just make it available to anyone who wants it. We do this. I'm about to take the QR code down. So if you don't have it, I ask you to kind of take one last look at that. But the reason that we do this, the reason I've kind of played this out is that we actually have 10 of these sessions. In each session, we cover a different tool and a different topic. All of them are intended to give you new kind of compartments on your utility belt of what you can do for well-being. We have one for 3 good things. We have one for hope, which we just talked about just now. This is actually the second webinar we give in the series. We have one for relationship resilience, about how to have a good kind of interaction with others. We have one for how to cultivate gratitude. We have one for work-life balance. We have one for mindfulness. We went for sleep quantity and sleep quality. That's a hugely popular one with our physicians. We have one for self-compassion, which is an increasingly popular one right now. After hope, I'd say self-compassion is probably the second or the third most popular tool right now. And it's a pretty low dose too that is required. Just to give you a sample here, gratitude takes 7 minutes. Self-compassion takes 7 minutes. Cultivating awe and wonder takes 7 minutes. 7 minutes one time, and that's the whole tool. For those examples, we do the whole tool in the webinar during the continuing education activity. There's no homework. You don't have to do something outside. We do that during that 45 to 55 minute block of time that we set aside for the continuing education, so that you can get your full dose during that session. Some of these tools, like the Looking Forward tool, are multiple day tools where every day for 8 days, we'll ask you a question that takes you a minute or 2 to answer for 8 days. The Work-Life Balance tool takes 2 to 3 minutes a day for 4 days. This is just to give you a sample of, when we say bite-sized, we mean it doesn't take more than a minute or 2, really to do this. And it's not supposed to be like one more thing, one more significant source of added stress. Now that you've seen these links and we've kind of shared what this is, I want to kind of back off and say, in addition to things that you can do for individuals and small groups, there are things that you can do for large groups and institutions, departments, work settings, and divisions. And that is, and I'll share with you how we kind of pull the connection between things that we do for individuals that are struggling with well-being in healthcare, and then groups of people that are struggling with well-being in healthcare. So let's talk about leadership. And I want to kind of share with you how these positive emotion concepts kind of dovetail in the way we can use leadership activities. And I define leadership as getting groups of people to do things that make the world a better place. And it can be quite the tightrope. It's hard to be a leader right now. If you're not burned out and you're a leader, what is wrong with you right now? It is really hard to be present and available to people when they are struggling so much with their well-being. But that said, let's say that you walk that tightrope. There's so much right now about psychological safety. I love this anti-motivational poster. If you see the fox here in the middle, when you're in deep trouble, say nothing and try to look like you know what you're doing. This reminds me of the saying, when in doubt, better to say nothing and be thought the fool than open your mouth and remove all doubt. People, there's a lot of disincentives to like speaking up and finding your voice. And this is all about psychological safety. This is what leaders can have a really big impact on right now, is the psychological safety of staff. And psych safety is this belief that you're not going to be punished or humiliated if you speak up with ideas or questions or concerns or mistakes. Now, we try to imbue psychological safety into group settings through rounding practices. And we have 3 different types of rounding practices that we cover. The first is called emotional support rounds. This is what we do during crisis or at or near crisis standards of care. We have chaplains and social workers and psychologists and others go and put a hand on the shoulder of a colleague and say, what do you need right now? Can I get you some food? Can I get you something to drink? Can I get you some coffee? Do you need to talk about what's happening right now? During the height of Delta and during the height of Omicron, we were doing emotional support rounding primarily. We've now kind of started to taper those off, and we're doing more safety rounding and positive rounding. Safety rounding, as you probably know, is this concept of you go around and you ask, hey, how are we going to kill the next patient around here? What can we do to prevent it? Well, you can probably tell that, during the height of Omicron, that was not the time to kind of ask this framework of people to mitigate risks to quality and safety. That said, I'm a really big fan of leader walk rounds, and asking questions in the right way makes a really big impact on culture and the well-being of the workforce. We've published many articles showing that. But the positive rounding frame, if we take this positive emotion thing seriously, the positive rounding frame tells us something kind of interesting. You could say, well, what are 3 things that are going well around here and 1 thing that could be better? Well, now by asking that in a positive framework, I've done something very special. I've asked you what you're looking forward to. I've asked you what you're inspired by or what you're grateful for. And in doing so, I've helped you to feel good about, well, this is what's going well around here. Oh, and there's this pebble in my shoe that I could use some help with. There's this one thing that's been pretty frustrating to me. And I've since I've told you, since I've told my leader about what's going well, I now feel comfortable telling them about this one thing they could help me with. That's a very different framework that builds psychological safety. It puts a plank in the bridge of access between staff and leaders. And that it makes that bridge more stable. So the next time, if it is something more serious, they're more likely to use that bridge to voice their concerns. That's about psychological safety. Well, we've published what this means in positive walkarounds, and the Joint Commission did an editorial on this. It was really nice of them. But the positive rounding frame, we elicit this by just asking on our standard safety culture and employee engagement surveys. We just put a question for every single healthcare worker. Do leaders ask about what's going well around here? And that question, do senior leaders ask about what's going well? We just look at the percent of people across our health system that said yes. This is about 400 different work settings. And you can see if we break it into quartiles, the fourth quartile there, not very many people are being asked about what's going well. And in the top quartile, the first quartile, most people are being asked about what's going well. And if you compare those quartiles, you'll see a very clear pattern about how this is associated with well-being of the workforce, the safety culture of the workforce, the engagement of the workforce. We work hand in hand with our HR colleagues to make this a reality. I'll share with you the improvement readiness, our capacity to do quality improvement and patient safety activities is better in those work settings where we're asked about what's going well. Our local leadership, my medical director, my nurse manager, my unit manager, I think more positively of them in work settings where I'm asked about what's going well. Teamwork is better in work settings where we ask about what's going well. Safety, would I feel safe being treated here as a patient? Yeah, more so when I'm asked about what's going well. Emotional exhaustion is the reverse pattern. I am less emotional exhausted when I work in a place where we ask about what's going well. How burned out, how crispy are my colleagues? How burned out are they? They are less burned out when I'm being asked about what's going well. And then work-life balance is better in work settings where we ask about what's going well. My goodness, what's happening here? Isn't that interesting? The reason I share with you the HOPE tool and then jumped into the rounding practices is to draw a connection between our individual resources that we develop for individual healthcare workers and then institutional resources like peer support, second victim support, psychologically safe leadership, positive walkarounds, traditional patient safety leadership walkarounds. All of them have this component of pausing and reflecting. In particular, pausing and reflecting on what's going well or what is going to go well. And that makes, ladies and gentlemen, all the difference in the world. So I'm going to give you another chance to get your hour of continuing education credit here in a second, but I wanted to say I'm about to give you a commercial. So buckle up. I'm gonna hijack about 3 minutes here of our conversation to kind of like push play on the commercial that we use for our well-being resources that we're now bringing through the health research, the HRSA, the Health Research and Services Administration, to the Michigan Hospital Association and to Duke. So before we start answering your questions, I do want to share with you what that kind of quick commercial looks like. The question that we get right now is how to improve my well-being during a global health crisis. We do this by delivering evidence-based, bite-sized well-being sessions virtually. And if you can't make those sessions live, we record them, and they're available for a year. Each of them is available for an hour of continuing education credits, CME and CEU. In those sessions, in each of these 10 sessions, and they start March 29th. I'll share that with you again. They start on March 29th. In each of these sessions, we pose and we answer some of the most common questions every single week. They're weekly on Tuesdays at noon, starting March 29th. Questions like, what's the simplest thing I can do for my well-being? Or how do I maximize my sleep quantity and sleep quality? Or how do you work with difficult colleagues? There are 10 of these sessions with an optional 11th one that is designed for implementation. How do you share the resources with colleagues instead of just using them, for yourself? The series will give you a new lens through which you can view evidence-based strategies to improve well-being in yourself and in others. And over the course of the 10 sessions, you're going to amass an impressive utility belt of all the diverse well-being strategies that we covered and talked about in the samples here today. All you need to do to get access to these is use your mobile phone. So here's the QR code for this session. It is WellBe 2022. It's all caps, WellBe 2022. Scan the QR code, or you can type it in. If you do that, we will send you an email, and the email will have a Zoom link for your calendar and a flyer. This is what the flyer looks like here on the right-hand side. This came to us courtesy of our colleagues at the Michigan Hospital Association. It starts March 29th. It goes Tuesdays from noon to 1 Eastern time. They're all recorded. If you can't make one, you can watch the recording. You can also use the recording to share the content with others. Some people just do it by themselves. Others are more active, and they take that recording and they organize some bagels or a lunch or something, and they allow people to watch the recording while they're providing food for folks. And they can grab continuing education credit. They can use the tools. They can share the tools with others. These tools are all designed to be pretty portable. You can use them on yourself. You can share them with your loved ones. You can share them. A lot of people use them with their kids. You're welcome to do so. These are very trying times, and we need some resources that can be pretty robust to lots of different applications like that. That was the quick commercial that I was talking to you about. I'll leave all the big QR codes up that we talked about today on the screen right now. I'd love to open it up and see what your questions are. The first is the QR code for the HOPE tool. The second one is for your hour of continuing education credit. Wait, if you do that one, you'll get the slides and the links and everything else. And then the third one here is the Michigan and Duke well-being sessions that are going to start March 29th. That's how you can get access to it. And if you've already enrolled, we would ask that you take that link and share that with other people so you can have some partners in crime to help with the well-being locally. Many hands make light the work, and it's one thing to be the one person who's taking on the responsibility of well-being in your institution. Believe me, I know what that's like. I definitely know what that's like. I'm not alone anymore, but for many years at Duke, I was like that annoying person that kept on pushing that agenda. But now we have large teams helping us with this, and it has spread so wonderfully. We'd like to give you the opportunity to spread that also locally in your institutions. And so with that, Adam, let me just kind of pause and see if there's any questions or in the chat.
Absolutely. Thanks so much, Brian. Great presentation. And again, for everybody on the line, I did drop the flyer link into the chat. So you can access the flyer that Brian just showed on the screenshot with the QR code and the bit.ly link. So you can either click the link or scan the QR code to go register, and feel free to share as widely as you'd like. This is open to any healthcare staff in Michigan. It's been extended to our PSO members in Indiana as well. So feel free to push this out. Clinical folks, non-clinical folks, doesn't matter what your role type is or specialty is at your organization. Everybody's really struggling with the burnout and the pandemic and everything that Brian went into. We do have one question that came in the chat, along with a number of other comments just saying excellent work, excellent presentation. But the question is, I was surprised, or I guess statement, and not a question. I was surprised that faith or spirituality were not on the positive emotion list. Do these fall under HOPE?
That's a great question. Thank you, Diane, for that. So faith is not like a positive emotion. It can cause positive emotion, but it's not a positive emotion per se. So yes, I would put that under hope and inspiration. Is where I would kind of put both of put the two emotions under there. I would also just say, independent of positive emotions, one of the things that we've learned is that those individuals that have a meaningful faith tradition that they follow for themselves, whatever that means for them, they have an additional layer of protection when it comes to emotional upheavals. So having a faith tradition that you rely on during trying times is certainly, across a lot of different studies, associated with more robust well-being. Doesn't mean you have to have faith to have well-being. It simply means that that is something that is measured independent of positive emotions as having a really powerful impact. I just wanted to make that little distinction there, but that's a great question.
Perfect. Thank you so much. And the one thing too, I'll point out, as we've been having conversations for weeks and weeks and months about this program and working one-on-one with hospitals who reach out to us who would like more information. The thing I really love about this is that, like you said, Brian, it's all inclusive. It's all the tools, the exercises, they're within the webinar. You don't have to put in time homework outside of the call. And in a world where we're just strapped for time and resources and all of the healthcare worker issues, shortages, and burnout and everything, I think that's a real big selling point. And anybody on the line, feel free to chime in on that as well. But just wanted to kind of reiterate that too.
I think it's a wonderful point. We're a time-starved society, to be sure, and we just don't have the energy to do really big, heavy lifts. That's why this is framed as bite-sized. There has to be simple things that you do in a minute or two a day, or you do it one time for 7 minutes and then you're done. Like, that's the idea behind it. And the fact that the randomized controlled trials show that even those single doses, of a small activity can have these enduring effects that go a month, 6 months, 12 months later. That's a really valuable use of 7 minutes, right? Is to put a little gas back in the tank, especially right now. That's a really important point. Thank you for making that.
Absolutely. And then the last thing I'll say too, that I'm not sure if you mentioned this or not, Brian, but again, this is being offered completely free of charge to all of you. And it's something that traditionally would not be free of charge. So this is a great opportunity to take advantage of this resource as as a free resource, really. So just a really good opportunity for the staff and for all of you on the call.
Yeah, and thanks for saying that too, because this is grant funded. So instead of we've done this with 13 different hospital associations where they paid for it. Now we're doing this for free through the Michigan Hospital Association. This is the first place where we're doing it in the country like this. But our hope is to bring this very broadly to healthcare workers across the country. It starts in Michigan first.
Wonderful.
Should we declare a victory? We can declare a victory for now.
I would say we can declare victory. I would say so. I think I'm on board with that. I'm not seeing any other comments chatted in or questions. Brian did put in a few links as well into the chat, so feel free to click those and explore those. There's some wonderful resources as well that are offered by Duke and by Brian and his team. One more comment. Brian, we are ever so grateful for your commitment to our Michigan hospitals over the years. Absolutely. I would echo that. If you don't know, our relationship with Brian dates back many, many, many years with all different kinds of quality and safety work and just a true friend of the MHA, the Keystone Center, the PSO, Michigan. I mean, your roots run deep here.
So thank you for saying that, Chris, and thank you for saying that, Adam. When we had to decide, were we going to do this in North Carolina or in Michigan, I said, well, I know we can do amazing things in Michigan because we've done them before with the Keystone ICU project. And it really made my North Carolina colleagues angry. So we're going to do them in year 2. But year 1, we're going to Michigan, baby. Michigan all the way. So that is our goal. Thank you for saying that, Chris, and thank you for your kind words. We just hope to make it available to as many people as possible, starting with all of our colleagues that live in Michigan or work with the Michigan Hospital Association.
Absolutely. Well, thanks again so much, Brian. Great presentation. Just for everybody on the call, again, this WellBe program kicks off March 29th, so you still have time to spread the work. Send the flyer out to your staff, talk about it in your meetings, register yourself, register your colleagues. Really, we just want to maximize the value of this across membership.
Want to say thank you for the introduction, Clarence. That we appreciate that. Incredible speakers today. We're just really super impressed. And before we really begin, we just want to say a few things. First of all, Jory and I very intentionally put a lot of content into this presentation, and we know there's not going to be enough time to cover every slide and every bullet point, but we wanted you to have this information anyway. Secondly, we must say thank you to MHA for inviting us to be your guest speaker on this incredibly important topic. And thirdly, a huge big thank you to all of you in healthcare. Wow. You've done an amazing job in the past 2 years, especially. And for that, we thank you from the bottom of our heart and we salute you. And that's why workplace violence prevention is so important to all of us. This presentation objectives are here to provide healthcare facilities with information that we believe will assist you prevent harm, minimize violence in the workplace, understand how the pandemic has impacted violence, and also how to best use the Joint Commission new workplace violence prevention standards. And then lastly, we wanted to showcase and show examples of programs and tools that we think might be of interest to you. And I'm going to turn this over to Jory right away.
Good afternoon, everyone. It's great to be here with you today. I want to say that I'm thankful that I have been able to care for over 1,000 COVID patients during the pandemic. And I've also, unfortunately, seen an increase in workplace violence in our healthcare settings. Due to these increases over the past several years, in 2018, the Joint Commission issued a call for action for reduction in workplace violence prevention against healthcare workers. And now in 2022, we'll be talking a little bit about the standards today that they have just implemented in January. This screen just shows some of the data that's out there. And as we know, of 25,000 workplace assaults that have happened, 75% of these are happening in our healthcare settings. And they just continue to rise to an all-time high. We also have workers leaving healthcare at a record rate. And this is really sad because healthcare workers get into this field because they love people so much and just want to care for patients. And we want to help them and support them to be able to continue to do this. We're also advocating for stronger legislation. And I'm pleased to say that currently under consideration in the Michigan House, you have a couple great bills out there, Bill 5682 and Bill 5084. Just wanted to mention these. You just keep an eye out to help support, talking about jail time, fines, and posting signs that, assaulting healthcare workers is a felony. So we're excited to see these bills and see how they progress through the House. Also, we've had some limited mental health support services in the past. I feel like Dr. Sexton did a great job of showing a lot of services that are out there to help support. And every day we're seeing more and more resources come out to give support to our healthcare professionals. Workplace violence has just been a risk to all of our employees out there. It's physically, emotionally exhausting, and it has led to a lot of turnover and burnout that we've seen just increasing every single year. These issues lead to personal problems at home and spill over into our homes. And also workplace violence, it just causes distractions for healthcare workers, and these can lead to additional errors and injuries for healthcare workers and for the patients that they serve. COVID also has contributed a lot to workplace violence. Now we have patients coming in, there's increased fear. Even just coming into the hospital for regular procedures now, there's increased fear that, what if I have COVID? And a lot of delayed treatment that we've seen. PPE for our elderly patients. This has made it really difficult. Someone comes into their room all dressed and it's hard to hear them. It's hard to see their faces. And also there's a depersonalization that happens when you're looking at someone with all this PPE on. And it makes it a little bit easier to lash out at these healthcare workers. We've seen an increase in patients with altered mental status and drugs, alcohol abuse, mental health issues. All of these have been on the increase, and these are all factors that have been contributing to workplace violence. And people have personal issues now also with unemployment and their finances. There's also been issues with family. They're unable to really spend the time that they need to with their loved ones that are in the hospital. And also conditions are a little bit more complicated now. We used to be able to tell a patient coming in for, say, a knee replacement, this is kind of what you can expect, and we'll give you a little PT, you'll go home tomorrow. But with COVID, it's been a little bit different. And this has been very frustrating for family members to not really know how long will their loved one be in the hospital, and what are the implications for COVID in the long term. We've also seen a lot of consequences for staff members. There's been, as we mentioned, a lot of burnout, frustration, and some issues with trust. Here we have organizations like the CDC that we have just trusted our entire time in healthcare. And due to the pandemic, and the uncertainty of what was happening around us, we need to build these trusts back up again. OSHA has recorded that illnesses and injuries among healthcare workers have increased 249%. And this carries over into their home and relationships. Good news is that there are some mitigating factors, some good management support. Get involved. The talk about leadership rounds that we just heard in the previous slide presentation, really important to go out and just support your teams. Let them know that you're there for them. And resiliency programs, again, daily, a lot more resiliency programs are coming out. Physical environment protection. How can we protect our employees in the physical environment, especially in high-risk areas like the ED and the ICU? And this environment of mutual respect behavior expectations form. Okay, this is a huge long word for a form, or just to have some type of form. We're recommending that you just sit down with a patient and talk about some of the behaviors that are expected while they are in the hospital. Employee surveys. We've gotten so much better at employee surveys. I see a lot of surveys coming through on SurveyMonkey, and I think this is a great tool to use. Workers feel like, I can really trust this survey, that it's totally anonymous and I can say what I really want to say and get my feelings out there. The IHI too has done a lot of research work on finding joy in work. These have just been exceptional research projects. And also,
okay.
The synergistic effect of workplace violence and COVID. In the last 24 months, there's been a significant increase in mental health issues and violence in patients, visitors, and staff. And we've seen a lot of serious staff shortages. I really like this diagram on the right. I think it really explains about the burnout cycle. There's the burnout that causes nursing turnover and shortages that cause inadequate staffing and job satisfaction, and then increased burnout. So as leaders, we're looking at this cycle just to see, like, what can we do to help with this cycle? What can we do to help support our healthcare workers who are exhausted and frustrated? And the synergistic effect of all these issues could produce multiple adverse outcomes, including reputational risk, injuries, and substandard patient care.
Joy and I were talking the other day, and we figured out that she's actually served over 1,000 COVID patients in the last 2+ years, over 1,000. And we got thinking about all the lessons we've learned. And really, the pandemic has taught us a lot of value-added lessons. We need to identify those lessons and begin to apply lessons learned to our workplace violence prevention program, especially when we're at the phase of restructuring and redirecting our resources, such as making sure we apply those lessons to our workplace violence prevention committee. Our training, patient screening, and PPE was huge. And post-event follow-up and debriefing, doing it timely and making sure that our employees feel supported in real time. And what we're really hoping for is that we will all witness a culture shift together. And the culture shift of, we now have got more national attention for workplace violence prevention in healthcare than we ever have. We're getting more legislation support. Therefore, the message is getting out there. It's a lot more than physical violence. It's much more than that. It's physical, and it's threatening behavior, and verbal. And sometimes verbal and threatening behavior is more damaging. Another cultural shift that we're seeing is a generational shift. For many, many years, it used to drive me crazy. I just hated to hear this. Ken, getting spit at, swung at, cussed at, it's all part of the job. No, it isn't. It never has been and never will be. But now we are getting experienced workers, and especially new generation workers, that are saying, no, that's not part of the job, and never getting hurt should be part of the job. And we want to strongly support that message. And so when it comes to workplace violence, it's amazing how much there is. And it's hard to get your arms around all that. And sometimes the hardest part is just, where do we begin? How do we get started? Well, I'm a huge, firm believer that it all starts with culture. And we have 3 recommendations here that we think will help us get started. Number 1, commit to a safe and just culture. Why? That's your foundation. That's who you are. So that safe and just culture of zero harm should include all aspects of workplace violence concerns regarding patient and visitor to staff, staff to staff. We have a long way to go there. Physician to staff, likewise. Domestic violence. All of these items, as Joy mentioned, they're all on the increase. And as she mentioned, we need to promote. In healthcare, we are the advocate. We should be the voice that says we want laws to protect all of our workers. Behavioral health, we can't say enough. We need more and more behavioral health support. Again, it's up to us to work together and stand together and just support healthcare in general. We don't want to see people leave. We don't want to see nurses leave the occupation and leave the hospital. In fact, I believe if we work together, stand together with one voice, we can reverse that trend by providing strong support programs like workplace violence. We can reverse that trend that says healthcare is a great industry and a great place to work. And this is the place we want our sons and our daughters and our grandchildren to work as a nurse, as a doctor. And I do believe we can reverse that trend by showcasing items like developing and implementing your workplace violence program. And we're going to do that by demonstrating the Joint Commission new workplace violence standards. And that's what the next several slides are about, to demonstrate those new standards from the Joint Commission. And I'm just going to summarize it real quickly on the right, then we'll talk about it in a little bit more detail. It starts with conducting an annual workplace violence prevention proactive analysis and an action plan, provide training, education, and resources, and a process to report, to monitor, and investigate your related events. And then what are you going to do with that data? Trend it, analyze it, and report it. And next is leadership. Leadership oversight. You have a designated leader and a multidisciplinary team that designs the program. That team will identify your entire written program, policies, procedures, process, forms, and then a separate section dedicated to a process for follow-up to support the victims and witnesses. And then lastly, reporting your violence events to your governing body, like your board. You know, whether you're a hospital system of 1 or 25, doesn't matter, doesn't change what I'm about to say. Every program you have should be standardized. One training program, one policy, it should be formalized. They're fully committed to it. It's not optional and highly structured. And the workers, that's what they appreciate the most, that it's highly structured. So let's go through these standards together. First, the hospital manages safety and security risk by providing a workplace violence prevention proactive analysis. It's an annual analysis related to your program. It covers all areas that's covered by Joint Commission. But we strongly recommend put a little bit extra effort and focus in your high risk areas. In other words, let the data lead you to where you spend most of your time and efforts, because it's the data that dictates this is where the high risk, the high injuries, the emergency department, behavioral health, ICU. And it would also carry over to the clinics if they're covered by a Joint Commission. But in the spirit of workplace violence prevention, we want to include all our clinics and other services. When you do this analysis, we strongly recommend use a written program. Now, a written program, I've seen several of them. There's many of them out there. And I've had several editions over the last many years. But the one that MHA produced, I think it was last year, was excellent. That's an excellent program. Whatever you use, whatever tool you use, we just recommend this. Use a tool that you can identify sections of all your program. And specifics that Joint Commission includes is this: events data, all your written programs, process and procedures, and your training program. So it's got to be very, very detailed and very specific. But Joint Commission actually takes it a couple steps further. And I really actually appreciate this a lot. They said, yeah, evaluate your program, but don't forget, you have to consider industry, healthcare, best practices. So we have to be aware of what that is and how to apply it and grow. That's how you grow. That's how you make a good program better and apply all the laws, all the regulations. So if you think about it, Just this part alone, this is your entire foundation of your workplace violence prevention program. And it's going to identify A to Z, and it's all inclusive. It also includes all of your Joint Commission standards. They're all in this section. Another part of it is this, the conditions of the environment. It's your walkthrough, the building itself, inside, outside. But don't forget, environment also includes people. People are the most important part of that environment. So when you're doing your walkthrough, you're going to want to talk to people, want to get feedback. Now, I've done a lot of these, and I just want to provide an example of a process that I think seems to work pretty well. I usually start and end with leadership meeting. Get the high-level leaders up front. And that's where you're going to ask the tough questions. That's where you're going to really get information that you're going to need that information throughout the day when you talk to managers and staff. Next is just that. Set up meetings with managers and staff interviews. Do you do that? Some of it's one-on-one, some of it's a group. We recommend both. Do a little bit of both. And then number 3, random interviews during your walkthrough. We've done a lot of these, and I will tell you, the random interviews are incredibly worthwhile, because you're going to get such great information, especially if you go to the ED and ICU and behavioral health. When you can catch a nurse and get a little bit of their time, they're not shy. They're going to open up. And the feedback that you get is so valuable to your program and how you're going to develop it. And lastly, summarize your report, use the completed form, and you're going to use that to develop your action plan based on your findings. Now, if you do it correctly, you can use that form, that gap analysis form or your checklist. If you do it correctly, that can turn into your action plan. I've actually talked directly to Joint Commission and asked them that question. They said, absolutely. If you do it the right way, you identify your action plan, the 2 is 1. And then annual review. I call it annual review. Joint Commission says annual analysis. First, you analyze all your information, then you do the annual review. And remember, because the entire Joint Commission standards are built into this, that kind of means you're going to review everything on an annual basis. The next part is your training program. Now, this is an HR Joint Commission standard. Says staff participate in ongoing education and training. That's a short, small statement, but very powerful. Staff, plural, several. Participate, ongoing. That's key. This is not a one and done. You don't put together your training program and sign off and go your way. This is the program that you're continually committed to, ongoing, and the hospital is committed to it. That's why the standard outlines that the hospital provides training, education, and resources to maintain that training and education. This applies to mandatory training for at the time of hire, annually, and whenever you make changes for your leadership, for your staff, and your licensed practitioners. At a minimum, it should include the definitions, de-escalation techniques in detail. It should include physical and non-physical intervention skills. And how do you recognize and respond to codes, alerts, and reporting systems? And number 4, roles and responsibilities of leadership, staff, security, and law enforcement. And I'm going to pause there for a second, because I will tell you, employees, really what makes the difference are your nurses. Nurses have told us over and over how much they value understanding what is our role, what is our responsibility. We're okay with that, but they need to know the roles and responsibility of leadership, of security, of law enforcement. Once they know and understand that, they feel so much better. They feel so much more confident in what you're doing. And then identify training for all staff. The reason why we included that bullet point there, Joint Commission knows you got a lot of staff in the building. Everyone doesn't have the same risk level, so you can adjust your training, to accommodate that. The next few slides is really, I just want to use some slides to kind of further explain some of these key points. Okay, Joint Commission says staff. We called it design and implementation team. And here's the team. This is an example of a team. Clinical. Clinical is bold for a reason. We strongly recommend that team should be clinical, and behavioral health, safety, security, risk management, infection control, and whoever you want to add to it. But nevertheless, that team needs to include clinical personnel that are not just in leadership, but in leadership and on the operational side, because they see it every day. Someone from the ED, they see it every day. Next, you've heard me say this. I'm going to continue to say it. Training. One size does not fit all. It just doesn't. Therefore, in your high-risk areas like ED, ICU, bedside, you need a stronger, more advanced training. And the feedback that we get all the time is that they appreciate the didactic, but they really, really appreciate the simulation training. And now that we're really advancing with COVID, we need to bring that back in if you haven't already. Start doing more simulation training. Then we provide drop-down menus because everyone has different roles and responsibilities. You know, sitters, restraint training, patient handling. And let's not forget your clinics and your home health care. Over to the right is kind of summary of what we're talking about, but really I just want to highlight the one word: prevention. You know, for so many years, our training was response training. And that is not going the direction that we are going. It's all about prevention. How do we identify warning signs? How we provide de-escalation, and that therefore we can prevent a situation. And we need to be very detailed in how we do that training. Your training should also identify what is your workplace violence plan? What are the tools that you use in your hospital? Be specific and be detailed. Here's our reporting process. And here's an illustration. This is what we're talking about. I like this slide a lot, behavioral continuum, because it's a terrific illustration. And I'll tell you, every nurse we've ever shared this with, they immediately identify with it. They identify immediately with the patients. And once we get into the conversation, I asked the question, I said, do you identify with yourself? So really what this is helping them to recognize the warning signs. And that's what they ask for. We want to recognize the warning signs, and they're pretty good at that. But we want to get really good at responding to them so that we can de-escalate it. What are the warning signs of anxious and agitated behavior so that we can apply de-escalation techniques and move it over to the left to the calm side using de-escalation programs like AIDIT and LEAPS. And I'll share that with you here in a second. Here's an outline of AIDIT and LEAPS. You know, there's a lot of detail on this page. That's the point. It's all in the approach, and it's all in the detail. So how we approach a situation and the detail that we prepare our workers for is going to make the difference. That's what matters. That's what takes a situation out of a high-risk area into a lower risk area if we approach it correctly and if we are trained to respond to it. So this whole point of this slide is it's all in the details, all going from good eye contact and communication. Next, you've seen slides like this before. The do's and the don'ts. There's several of them. Really, the only point I want to make here is why is that so important? And why it's important, at the very top, it tells you trigger avoidance strategies. Once you understand and get a better understanding and training of what is a trigger avoidance strategies, then the do's and don'ts make a lot more sense. You know, if you have never received that type of training, we highly recommend it, and then apply it to your program. And then this is kind of a summary of some of the targeted training programs that we talked about: safety, attendance, sitters, restraints. But what about phone? We definitely need to make sure that we are providing information to our caregivers about how to de-escalate over the phone. And your other care teams, there's a lot more outside the hospital. What about home health care? I think that is a huge, huge area for our future. And then also helping our own patients to communicate. Joy's got story after story how just helping a patient to connect with the home really de-escalates the situation.
And then how do we communicate in some of these more challenging situations, like being proactive to rising problems? You have some challenging situations with families and visitors. How can we use these as opportunities to maybe pull them off and do a consult and maybe talk to them about how we can adjust the care plan for their family member? Using our resources. The hospital has tons of resources. We have a lot of people that we can call upon to help us in these situations of communication, and also communicating for our caregivers, for ourselves. Some of these escalating behaviors and verbal abuse that are suffered, not to take it personally and do a self-check as a caregiver to, what do I need right now and how can I find things to de-stress myself.
The next Joint Commission standard is this. The hospital collects information to monitor conditions of the environment. And what they're talking about is really a process to manage your workplace violence and security events, your incidents, if you will. And it starts with internal reporting of events. And I'm gonna stop there for a second. That's a problem. In fact, there's a quote right here. It says, underreporting is thought to be a major problem. And that is not a quote from us. That is a quote directly from the Joint Commission. It is true. And we all know that we underreport. Any ED is really, they experience it every week. Underreporting is something that we really need to start looking at and working together. How do we change that direction? How do we increase the reporting? I believe it's a different process. It's a different summary, but we do need to definitely look at it, address it, and identify how do we improve the reporting events on a more consistent basis. And Joint Commission says continually monitoring. That's very interesting. And I would take that literally. Continually monitoring means this. What about the events that occurred last night? What about the events that happened on Saturday or Sunday? Who identifies with that? How is that being communicated in a timely basis and investigated in a timely basis? Because the timeliness is so critically important. That is the best time to identify the risk factors, the gaps, vulnerable areas. And that's when you apply your environmental controls and mitigation strategies. So the timingness and the consistency is going to be extremely important. And I wouldn't be at all surprised if hospitals are challenged with the question, how do you explain to me, how do you continually monitor your events on a 24/7, 365 basis? And then next, we're going to keep gathering all that data because we're going to use that data later on to do some trend analysis and we're going to do some, gap analysis. We're going to use that data for several things. When we do the investigation, it's not enough to say, yeah, do a timely investigation. I've had too many people tell me, Ken, accident investigations, they don't really work. They're not that effective. I don't agree. I think when you do an accident investigation the correct way, the right way, they can be very effective. And really, it's about partnering and problem solving together. So I would say spend some time and invest in this about how to do a proper accident investigation or incident investigation, because the benefits are huge. And doing that time is so important. Use a form, use a process, but be consistent. And then lastly, we're going to report that data up in a dashboard or a monthly report. The last one that we're going to talk about is about leadership. The leaders create and maintain a culture of safety and quality throughout the hospital. And what we're talking about is the workplace violence program should be led by a designated individual and developed by a multidisciplinary team. For years, we called that designated individual the champion. Who's your champion? Who is that person? And we're not quite there yet. We're in the process of identifying that person. But let me put it in blunt terms. I want a name. I want to know their name, their phone number, their title. Who is accountable and responsible for this overall program? Not to place blame, not to point the finger if something goes wrong. That's not the issue. The issue is we need a strong leader to help lead. How do we promote it? How do we advance it? How do we do better? That person should be an executive. That person should be your CNO or an executive level. And then developed by a multidisciplinary team means just that. It's the same concept that we shared about the training. It's not just leadership. It's not just managers and directors. This is truly a multidisciplinary team of clinical, of non-clinical. It should be areas of leadership and operational. And I would even go so far to say age. We need experienced folks and don't forget the new folks coming in. They have some awesome, terrific ideas, and we need to include them. What they're going to do is they're going to review the entire program, the work, everything in writing, the policies, the procedures, the process, all the forms, with the same focus point. How do we prevent it and how do we respond to workplace violence? And then not only that, review that process that we've been doing about reporting. This is a golden opportunity right here. How do we work together to increase reporting? Because what you're going to do, this group is responsible for making sure it's communicated to upper management and all the way to the governing body on a regular basis, or the board, if you will. And then next, do you have identified specific procedure for follow-up and support the victims and witnesses? And what we're not talking about here is looking at someone and saying, would you like the information for EAP or handing them a card? It's far more developed than that. We need a developed program that helps our workers in real time. You know, the items that Joy was going to, she'll share with you some examples of that. But they don't need help in 3 weeks. They need help today, tomorrow, next week, and in 3 weeks. And I'm going to turn this back over to Joy because we've got some tools and some examples and some forms that we're going to share with you. And she's going to kind of expand a little bit on the risk assessment that we've been talking about.
So what we recommend highly is an evaluation of your workplace violence prevention assessment and your communication tools that you're using, as well as your security and surveillance program. And as far as the assessment and tools that I have listed here, I'm going to cover these a little bit more in detail on the following pages. The risk assessment of your security and surveillance program, talking about your signage. You know, do you have signage outside your hospital or inside your entryways that say like workplace violence will not be tolerated in our facility, and spelling it out for the general public, what exactly that you mean. Your camera areas, badge alarms, panic buttons and alerts. If you look at the bottom of this screen is a little Centrex tracker. This is actually something that I'm wearing when I'm going to work. And these trackers are fantastic because they can track me anywhere in the building, and I can press that red button and the staff would know immediately where I am at and that I need help. And this is a great for workplace violence prevention, as well as making sure that your patient's belongings are screened before coming into the hospitals, into your inpatient units, just to help prevent violence. When we call a code, in the hospital that I work at, we actually have 2 levels of code gray. One is a tier 1 code gray, which is we know that this person is having some verbal behavior, maybe starting to amp up a little bit. And we also have a tier 2, which means that they're actively doing threatening behaviors, and also maybe they have hurt someone. So the best thing that we have is emergency response teams that will come. So these behavioral response teams have been just great for the system. There's several programs out there. There's behavioral emergency response teams, behavioral emergency support teams. You've probably heard of threat assessment teams. And these are teams that come in real time. So when we call a code, we have a group of people coming to help. These people are strongly trained in de-escalation techniques. And then also they're able to provide a clinical, a mental, and a medical evaluation of the patient as well. So on the bottom screen here on the right, you'll see that this is just an example of a form you can use for follow-up that you've done after an event, just to make sure that you are covering all these different areas. And also communicating with the teams. How are we communicating on our floors and to everyone in the hospital that we have high-risk behavior patients on this unit? Are we using certain gowns, socks to denote high risk, or putting little signs or magnets on doorways? And how are we handing off from staff to staff to make sure that this is communicated? Also, situational awareness. So on a daily safety huddle, if I'm coming into a unit, are they letting us know that, like in room 2, maybe we had a patient bite someone a few days ago, or a patient in room 32 is starting to amp up a little bit today, and we all need to be aware so that we can help support one another. I wanted to talk a little bit about safety attendants, also called sitters, because these individuals will sit with the patient that is aggressive or someone with altered mental status for 12 hours at a time. And this can be just physically and emotionally exhausting. We've come up with a safety checklist that caregivers can use at a handoff from shift to shift. Also, Ken came up with this cart with a sign that we implemented at our hospitals just to show outside the room that there is a risk of violence with this patient in this room. I'm also strongly recommending that you rotate these safety attendants. These are usually CNAs, and you're using them on the floor and also as sitters. So you can rotate them out about every 4 hours. It would be extremely helpful to them. And also, I have a question at the bottom of the screen. Should safety camera monitoring be used with or without a sitter? So we have these virtual monitoring technologies now where a person can sit and monitor 6 to 12 patients at a time. And sometimes we can use these cameras without using a sitter if the patient condition warrants. Other times, if there's a sitter in there and we know that this patient can be aggressive, we can also put a safety camera in there for additional protection for our sitter. So if anything were to happen in that room, could set out an immediate alarm or call a code. This is one of my favorite assessment tools. This is the Brosette Violence Assessment Tool. And what this can do is this can help predict violence over the next 24 hours. So just a simple assessment tool that a nurse can use. It takes a few minutes. What you do is you see these on the left, you'll see different behaviors of patients. They can just score them either a 1 or a 0. On the right, you see you can rate the patient as either a green, a yellow, or a red. A higher score will activate this early warning system where a care plan can be initiated with clinical, a pharmacy, some case management, maybe some mental health support to better support these patients. And how can other team members see the risk level? Over here on the right, you can see in the Epic, in one of the columns, it shows if this patient is a yellow, if they're a red, or if they were black. And this will let anybody know that the level of possible risk of this patient. Another way we can communicate high risk using the Epic is this is a patient chart. The nurse, if they don't click off that the patient doesn't have any high risk behaviors, it will add either a high risk patient alert or a high risk visitor alert. Now anyone that will pull up the chart will see this alert and be aware that there could be a potential for violence. Also, if you have a patient that walks out of your hospital AMA and they go across town to one of your clinics or perhaps another one of your hospitals and they pull this chart up, they can see immediately that this is a potential for high risk. Restraint safety checklist. This was a great tool that Ken and his team put together. This shows the best way to put on restraints. And this is not something that you would use during a restraint call because, as we know, these things usually happen pretty urgently. This is something that you would use afterwards at a debrief to see how did we do on a restraint application and what could we possibly do better next time. And most importantly of all with workplace violence is how do we care for our caregivers? How do we take care of our staff that have dedicated their lives to taking care of our patients and really caring about everything on the floor? We need to put some strategies in for resilience, and to see what do our caregivers need. As Ken mentioned before, if you ask a nurse after an event, do you need additional support? Do you want me to call you? Most often they'll say, oh, no, I'm fine. Everything is fine. But things are not always fine. So we do need to follow up. As he said, this is great for leaders to be able to follow up in a day, couple days, next week, and just for as long as it takes. Also resources, code caring is a program that I was heavily involved in. And this is a peer-to-peer support in real time. It just to be there for each other. Care for You, First Call. Brian also mentioned about the Duke Center for Healthcare Safety Resources and has provided a lot of really good resources. I suggest that you check into those as well. We're using a program called REST, Resilience Education and Support Training, which is great for self-care. A lot of really good resources out there, and also partnering with your community. It's amazing how much the community will step up and provide. We've had communities step up and provide sports tickets, event tickets, provide facilities for retreats for our staff. Just a lot of really good resources out there to help support our caregivers.
So this slide really summarizes everything we talked about today, and I won't go over this word for word, but in summary, really it starts with applying the lessons we learned from COVID to develop and establish a very firm foundation of a safe and just culture that directly impacts all areas of workplace violence. And then perform a proactive, comprehensive program analysis with an action plan. And you're going to do that every year. And then that information below really describes the details of what should be in that action plan and what should be on really your workplace violence program: leadership, training, data collection, and communication, all the way up to the governing body. Evaluate all your written programs, process, and forms. And we strongly recommend an employee survey. And then lastly, provide that process to support victims. When you do this, periodically, not just again, one and done, launch a program, really highlight certain things throughout the year. You know what doesn't work too well? You do the training and then you don't do anything for a year. We highly recommend that in the middle, highlight some key areas from time to time. Have a monthly plan. This month's topic or focus is, and you can focus on something specific. Then review and analyze on an annual basis. Why do we do all this? Because this is how we're really going to impact our own culture and our community. We are committed to that safe and just culture of zero harm. And really, we've mentioned it many times, and there's a reason why we keep repeating resiliency, because it's really so big right now. I love the community partnership. How do we get better with the community and understand the training that we need for diversity, equity, and inclusion? Use your resources. There's a lot of them. There's so many. There's study and research program. This is a little bit older one, this one from MSU with Dr. Judith Arnett, but it's excellent. Your working groups. There's so many working groups and organizations like MHA, Michigan Safety Conference, Michigan Healthcare Safety Association, and individuals. You've got a lot of great contacts right there in Michigan. John Boldy and Munson, Mary Ann Northcote at McLaren, Debbie DiNapoli at Michigan, and the list just goes on. And then utilize your websites. After today's presentation, we're going to change the slide. We're going to add some more of these contacts. We started off with this one at the top because it's really excellent. They have a depth of information and they have a few years head start on us. But this is the program that was developed by the Oregon and Washington Public Health. It was led by someone by the name of Linda Enos, and with her permission, we've provided all this information for you to access. And it's, again, a depth of information. Well, my favorite one is actually the Joint Commission. In blue there, you see where it says Workplace Violence Compendium of Resources. Wow, that is probably the best resource I've ever seen on workplace violence. And I could spend hours on that one. And then always, we're here for you from Healthcare Safety Services. And really, MHA is the center of support for everything you do. And with that, we just want to say thank you for attending. Joy and I, this is our favorite spot, Rocky Mountain National Park, 40 years strong. And we want to say thank you. Adam, we'll turn it back over to you.
Thank you so much, Ken and Joy. That was just a fantastic presentation, chock full of great resources. Thank you for sharing your wealth of experience and knowledge with us. So we did have a couple comments that came in the chat, and one of them I'll piggyback off of and sort of turn it into a question a little bit. One comment from Holly is that My Michigan Health started using the Brosette in 2020. I think the staff like it, is what Holly said. And I've heard similar things across the board with everyone I've spoken to, that the Brosette tool is just a fantastic place to start. Certainly if you don't have anything you're currently doing. So that's great. And then, so the second comment and kind of a question here is for organizations who are strapped for resources, who don't have the big budget of being part of a system or being part of a larger organization. So our rural health, critical access organizations who may not have the in-house resources and expertise. And one comment pointed out, we don't even have security. It's the old story of who's the biggest person that we can get a hold of who works here to try to restrain or de-escalate or do something, be sort of a show of force. So for those members, for those organizations, and I know there's many of them on the call, is there one thing, Joy and Ken, you would recommend that they could do, or multiple things, or I guess what would be your approach? What would you say to those organizations? Because this is an issue that keeps being brought up year after year.
Yeah, Adam, that brings up an incredibly outstanding point, because it's critically real. And it goes back to my comment, like, how do you get your arms around all this? And so I have worked with hospitals that said exactly what you just said. We don't have that. We can't put 6 people on every restraint. We just don't have the resources. And we get that. We understand that. And so my answer would be this. I would still do a very robust, comprehensive workplace violence prevention analysis. And then look at your action plan and begin with, what can you do? Begin with the process, prioritize it. We can't do 12 things, especially all at once. We don't have that. But what is the 1 or 2 or 3 items that you can start to do and do a good job? So that would be my feedback to any hospital of any size. Do that analysis and begin an action plan. That action plan may take you quite some time, but at least you're beginning somewhere. Don't delay, don't wait, and figure out what can we do, and how do we start to utilize? I think the area of those hospitals that we underestimate are the resources that are out there that are willing to help and support. Like MHA, you mentioned about having someone to come out and do that analysis. There you go. That is a prime example of what we're talking about. Mm-hmm. So start and do what you can.
Great. Thank you so much for that response. And as you said, this is perfect timing, because in the next year, really beginning later this year in 2022, we're going to be putting that funding, that partnership funding with Blue Cross to work. We're going to put those dollars to work and see what we can do and how we can maximize the support we provide to our members. And then the other thing too, I'm going to drop this in the chat. These are freely available workplace safety posters that were created by MHA. They're free to MHA members. There's a way, if you go to that link, there's an order form that you can request complimentary versions or copies of various different versions that were created, basically saying and covering a lot of what you were talking about, Ken and Joy, that no, this is not part of the job. We are here as staff members to care for you, to ensure safety, and that you leave this place in a better state than you came in, but not at the expense of our safety as healthcare staff. I think it's a strong message. So again, those posters are available, and you can order them online. And then let's see, we just had another comment come in. Thank you, Ken and Joy, for all of your work assisting McLaren Healthcare this past year. Wonderful presentation. So you have some partners out there in the attendee participant group as well, thanking you for your work. So that's fantastic. Let's see here. I'm not seeing any other questions in the chat. We'll give it a couple more seconds here. And thank you. It looks like Clarence posted the link to the PSO online community, where you can find resources, including this presentation, and then anything that the speakers send us after today's meeting, we will post there as well. So it'll kind of be your go-to hub to access all of that material. Ken and Joy, anything else from your end?
We just want to encourage everyone out there. It's not an easy task. There's no simple approach. However, we do highly encourage you to, move forward, keep moving onward and upward. Everything you do, especially when you can get the message out, how much, employees, what they want more than anything else. Employees want to know that someone's listening,
Right.
and that somebody cares, and that you're doing something. And I think that's really important, is that you're listening, you're responding, and you're doing something. You don't have to do everything at once. No one can, nobody.
Right.
And it is a huge challenge. So just keep moving forward in that direction, and you'll get some pretty powerful and positive results.
Absolutely. Message is well received. Well, thank you again so much, Ken and Joy, for your wonderful presentation. And we will move on to kind of the last part of today's meeting. And just a couple ending reminders. So again, these couple reminders here. These appeared on the break slides that we had throughout the day. OSHA data submission for the workplace safety effort is ongoing, open to all members. We currently have 55 plus hospitals who have submitted their workplace safety data. So this would be the recordable incident rates to us. So we're using that again to help drive our work forward and in partnership with Blue Cross. So I've just realized now too that you can't click these links. So the Key Metrics portal link, though, we can send that out in our follow-up e-alert to everybody who participated and logged in today. Or you can always email keystonedata@mha.org if you have any questions on whether you are currently submitting OSHA data or have historically done it, or if you just want to learn more about the work and start submitting data. And then we heard from Brian Sexton, and we've sort of blasted this link and QR code all over the place today. So that is to the WellBe registration information. And then if we go to the next slide, thank you, Clarence. Okay, so continuing education credits, we were awarded 4.5 credits for today's meeting. You can claim either nursing credits, risk management credits, or there's an other selection as well if you just need general credits and a certificate of participation. We can provide that to you. So expect to receive an email or an e-alert from the Keystone Center. So it will come from us with an evaluation link, and you have to complete that evaluation in order to claim your CEs. It will be open for 2 weeks from today, so it'll be open and then closing March 23rd. So please keep that in mind, and we'll put that information in the alert as well. So you can go ahead and claim your credits that way. And then as part of the evaluation too, certainly it's a way to ensure that you participated and you can claim your credits. But we also put a few questions in there, and an open-ended question to ask about what types of education you would like to see in the future. Are there certain topics either discussed today or something we didn't cover today that you would like to see us bring in subject matter experts or national experts to do educational webinars or trainings? And then maybe, hopefully, eventually we'll get back to some in-person events down the road. So we do value your feedback and take it to heart, and we will do everything possible to act upon that feedback as well. And then finally, and I know Clarence put this in the chat, but all of the slides from today's presentations, any supplemental material, I mentioned that the journal article from the Cleveland Clinic that Darren mentioned earlier today has been posted there as well. So all of that information is currently posted on the PSO online community. If you don't have access to that, you can just reach out to us, email us, and we'll just flip a switch on the back end and get you access to that. So that's pretty straightforward. And then finally, one last thing I wanted to mention, and I will drop this in the chat as well, is that Patient Safety Awareness Week is next week. So the IHI has a lot of great resources. I put the link in there. Please feel free to celebrate this as much as possible within your organizations And I saw that our Keystone Center just sent an e-alert out to members about it as well with some additional resources. So hopefully we all have some time next week to observe National Patient Safety Awareness Week. All right, and with that, I am just going to check the chat one more time. Thank you all so much for your engagement and your participation in chatting things in and contributing to the conversation. This is really what we're looking for. I know it's a little tougher in the virtual world, whereas when we were all in person, we could just speak into a microphone and you had presenters right there to answer your questions. But if any other questions do come up after this meeting, please don't hesitate to reach out to us. We will be compiling a list of questions that came in that the speakers could not answer because we didn't have time or they needed to do a little digging on their end. So we will post that as well